día a todos. Hola Darío, ¿cómo estás?
Hola Cari, buen día, hola a todos. Gracias nuevamente por acompañarnos en esta mañana de sábado. Ya siendo las 9 en
En
punto, vamos a
punto,
comenzando
hora
a
de
saludar,
Argentina,
¿no? Hora de
hora de
Argentina, sí, sí, sí,
Argentina,
acá
porque
3 de la
hay
tarde
muchas,
acá.
3 de la tarde en Israel para Darío. ¿Cómo estás, Darío?
Acá estamos como tratando de surfear estos momentos. La verdad, bastante difíciles, pero bueno, nada,
Hay
tratamos de seguir. Así que vamos a tratar
muchos
de.
mensajes de apoyo el sábado pasado para vos, para todo lo que están viviendo en Israel. Así que un fuerte abrazo. Estás viendo la presentación del curso que vamos a dictar en el 2024. Recordemos que no están abiertas las inscripciones. Es importante eso porque si no van a empezar a escribir, nosotros ¿dónde lo vamos a comunicar? Lo vamos a comunicar a través de las redes sociales de la comunidad latinoamericana de imagenólogos mamarios, CLIN, tanto en Facebook como en Instagram, y también a través de Tecnoimagen. Darío, ¿nos querés contar un poquito de qué se va a tratar este curso online?
Sí, Cari, vamos a tener un curso que va a ser para el año 2024, va a ser el sábado 20 y 27 de abril y los sábados 4 y 11 de mayo, en donde va a ser un curso online de la comunidad latinoamericana de imagenologos mamarios, desenmascarando los signos y dilemas de la práctica diario. Va a ser el primer curso del 2024, online y gratuito. Contanos, Cari, qué van a constar esas 4 charlas.
Mira, estas 4 charlas van a estar divididos en 4 sábados y los que vamos a estar presentando estas clases, después vamos a estar presenciales en el curso que vamos a dictar en Buenos Aires en junio. Así que vamos a contar con la presencia de 2 grandes disertantes muy queridos y realmente esperados. Nuevamente va a estar con nosotros el doctor Vicente Martínez en Argentina y también va a estar por primera vez, por lo menos con nosotros en la comunidad presencial en Argentina, la doctora Ruby Espejo. Así que bueno, va a ser un adelanto de lo que vamos a vivir en Buenos Aires. El sábado 20 de abril vamos a hablar sobre claves para el diagnóstico, signos en imágenes mamarias, que va a abordar un poco todos los signos que vemos en mamografía, en ecografía, en resonancia magnética, y que nos den tips para poder llegar a resolver esos casos problemas. Cómo poder a veces diferenciar de un fibroadenoma, de estos que son dudosos, ¿no? Los que son típicamente, ¿no? En las imágenes, de aquellos que puedan presentarnos dudas para evitar biopsias. Está pensado así esta presentación y después vamos a tener la discusión de un caso clínico multidisciplinario. Y esta vez vamos a invitar a equipos de trabajo para que nos cuenten cómo ellos resuelven los casos y siempre con la votación interactiva del público. Y el sábado
Perfecto, esa clase
27,
la va a dar Cari, ¿no? O sea, nos dijiste, la primera clase va a estar a cargo de Cari, así que realmente no se la pierdan. Yo ya estuve pispeando un poco y como dije antes, están todos los signos que nosotros leemos y a veces no entendemos. Cari con su paciencia y como siempre hace, nos lo va a explicar claramente. El sábado 27, o sea, el otro sábado, vamos a hablar, barra 3, mamográfico y ecográfico, cómo mantenerlo a raya. Eso va a estar a cargo de la doctora Ruby Espejo de México, y creo que es un tema que nos abarca a todos y que generalmente nos preocupa. Así que eso hace para el sábado 27. Después, Cari, ¿cómo seguimos?
seguimos el sábado 4 de mayo, cuándo sí y cuándo no solicitar una resonancia magnética nuclear. Hoy nos va a enseñar Vicente sobre cuándo biopsiar y cuándo no, pero en este caso es tan importante saber cuándo indicar, cuando sobre todo tenemos que cuidar, ¿no? Todos los recursos en salud y a veces porque por pedir a veces cosas que no corresponden o en fechas que no corresponden, nos dan más dolores de cabeza que soluciones. Así que en manos de un experto como el doctor Vicente Martínez, vamos a tener el sí y el no de la resonancia magnética nuclear.
Perfecto.
Y
Y
el,
finalmente, el sábado 11 de mayo, vamos a hablar de luces y sombras de la mamografía contrastada. Creo que la mamografía contrastada es una técnica que está creciendo cada vez más en las distintas partes del mundo. Ya tuvimos la semana pasada una linda charla, no sobre mamografía contrastada, pero de su importante uso, que ya está también empezando a usarse más en Estados Unidos, donde tardaron en tomarla o en empezar a realizarla. Y bueno, vamos a hablar un poco cómo se hace, cuáles son los problemas, cómo nos puede ayudar. Lo vamos a ver eso. Les voy a dar yo la charla el sábado 11 de mayo.
Excelente también, yo también estuve pifiando tu charla, Darío, excelente, todo lo que nos va a contar, porque a veces te cuentan siempre los casos éxitos, pero Darío nos va a contar las sombras también, ¿no? A veces las dificultades que podemos tener en la práctica diaria y cómo él lo resuelve. Así que imperdible la charla del 11 de mayo dada por Darío. Vamos entonces a junio, esta ya es en Buenos Aires, para aquellos que quieran ir comprando los tickets aéreos para venir a Buenos Aires con
Yo ya lo
tiempo.
compré.
Vos ya lo compraste, me dijo Darío, me amenazó, me dijo, Karina, esta fecha no se mueve, no se mueve. No tenemos todavía la locación, creemos que ya casi que la tenemos, pero todavía es a confirmar, tampoco están abiertas las inscripciones, pero lo vamos a hacer. Va a ser el tercer curso internacional teórico-práctico de la Comunidad Latinoamericana de Imagenólogos Mamarios. Los directores, el doctor Darío Sheckman y quien le habla, Karina Pesce. Este es un curso arancelado. Contanos un poquito la modalidad, Darío, que va a ser este
Vamos
curso.
a tener, como siempre, el viernes 21 y el sábado 22 de junio, vamos a tener la parte teórico-práctica, en donde van a ser sobre todo la parte teórica, donde va a estar invitado el doctor Vicente Martínez, la doctora Rubí Espejo, como dijimos, y vamos a hacer unas charlas que siempre tratamos que sean lo más práctico posibles, en donde vamos a tener durante todo el día viernes y hasta la mitad del día sábado, como ya están acostumbrados a los cursos que realizamos en Buenos Aires. Y después el sábado por la tarde vamos a tener el taller de intervencionismo mamario, en donde junto con distintos expertos en intervencionismo mamario por ultrasonido, vamos a hacer un taller para hacer y para enseñar y para practicar hacer todo lo que es los procedimientos intervencionistas. Va a haber unas clases teóricas, bueno, todo como lo vamos a ir contando a medida que va a ir avanzando en el tiempo. Y Cari, el domingo, ¿qué vamos a tener?
El domingo vamos a tener el taller exclusivo de imagenología mamaria. El año pasado fue nuestra primera experiencia. La verdad que los comentarios, la devolución, ¿no?, en las encuestas de satisfacción de quienes participaron, nos alientan a continuar con este taller exclusivo de imagenología mamaria, en donde realmente es un taller práctico, en donde mostramos casos clínicos reales, la resolución con las imágenes, mamografía, tomosíntesis, ecografía, resonancia magnética nuclear. Bueno, en este caso Darío también va a sumar casos de mamografía contrastada con el resultado de la anatomía patológica. Eso es lo que le da el plus a esto, porque realmente sabemos qué significaba cada una de estas imágenes. Así que bueno, los cupos, a diferencia de lo que va a ser el curso, que en donde tenemos mayor espacio, como queremos que sea muy más uno a uno, es bastante limitada, entonces cuando vamos a abrir la inscripción, lo vamos a anunciar por nuestras redes sociales y los cupos son limitados. El año pasado hubo lamentablemente gente que se quedó afuera y esperamos que este año apenas abramos la inscripción, puedan anotarse para no perderse su lugar, ¿no, Darío?
Exactamente, exactamente. Seguramente para más fin de año, principio del 2024, vamos a empezar ya con todas las inscripciones y la descripción exacta de los cursos y del congreso.
Pero bueno, que
Así
vayan
que,
agendando la fecha y
sí,
quienes
la
ya
fecha
quieren
ya no se mueve.
viajar, no se mueve, y quienes quieran comprar el ticket aéreo o quienes vivan en Argentina, quieran reservarse ese fin de semana para viajar, bueno, sepan que esa va a ser la fecha, porque aparte Darío ya compró su ticket aéreo, así que me amenazó. ¿Y cuáles son las redes sociales, Darío?
Bueno, tenemos eso, es gran manejo de Cari, tengo que decir, tenemos Facebook, tenemos Instagram, donde se pueden comunicar, donde la idea es que podamos compartir, puedan presentar casos, puedan poner cuáles son sus dudas, y a medida que vamos pudiendo, lo vamos compartiendo entre todos, ¿no? Queremos que esta sea una comunidad y que dentro de la comunidad todos podamos compartir. Cuando hablamos de imaginólogos, recuerden que no son solo radiólogos, sino que son todos los que manejan la patología mamaria: radiólogos, mastólogos, ginecólogos, oncólogos, radioterapeutas, técnicos radiólogos, todos. Queremos que estar todos juntos porque creemos que es la mejor forma de tratar a nuestras pacientes.
Un equipo integral, todos anatomopatólogos. ¿Cómo es darle me gusta en las redes sociales de Instagram y de Facebook? Hay un grupo después, además de la página, tenemos un grupo cerrado en donde, como dice Darío, compartimos casos clínicos, cuidamos siempre de que no haya ningún dato que pueda identificar a una paciente, y solamente en este grupo está formado por los profesionales que forman parte de esta comunidad latinoamericana, y la verdad que es un gusto ver cómo comparten, y con un respeto todos damos la opinión con respecto al caso de desafío que presenta el colega que está compartiendo en las redes sociales. Así que los invitamos a sumarse, y ahí también vamos a ir compartiendo los adelantos de toda la actividad académica que realicemos bajo la comunidad latinoamericana de imagenólogos mamarios CLIN. Darle me gusta a Facebook y a Instagram. Y ahora sí, vamos a presentar, a comenzar, porque a las 9:15 tenemos en punto que comenzar con la charla del doctor Vicente Martínez. Vamos a presentar este curso Cáncer de Mama de Manejos y Controversias 2023, organizado por la Humberto Veronesi Academy y la Universidad de San Diego. Este curso, cuyo director es el doctor Gabriel Farante, de la Humberto Veronesi Academy, y debemos contarle que ¿cuántos somos los que nos hemos inscrito a este curso y que han participado en el curso de la semana pasada?
Somos más de 4.000 inscriptos que nos ven desde todas partes del mundo. Realmente ahí tenemos, es un honor para nosotros poder presentar este curso y que tenemos que felicitar sobre todo a Gabriel, que fue el gran hacedor, el que estuvo atrás de casi todas las charlas. Así que Gabriel, muchísimas gracias por el esfuerzo que haces para que llegue todo esto a todo lo que es el hispanohablante, ¿no? Diríamos, porque es donde más está orientado, y que ahora, bueno, en un ratito nos va a dar unas pequeñas palabras de bienvenida.
Y le damos el lugar al doctor Gabriel Farante para que pueda dar las palabras de bienvenida. Gabriel, te escuchamos.
Muchas gracias, Karina. Muchas gracias, Darío. Solo un par de minutos para decirle que realmente la Humberto Veronesi Academy está muy orgullosa de organizar, promover y proponer este curso, que es el cuarto, que se realiza por cuarto año consecutivo, que se está convirtiendo poco a poco en la joya científica de fin de año, luego de que durante el año recibimos 1000 propuestas científicas para cursos, congresos y otras actividades. Este curso no se podría hacer sin alguno de los tres pilares sobre los que se apoya fallara. Son tres pilares que son, en primer lugar, y que es como la corona del curso, es el grupo de speakers de alto nivel internacional, que son el punto de referencia internacional, y que a pesar de su importancia científica y práctica en las instituciones a las que pertenecen, con una modestia, una sencillez y una generosidad increíble, participan cada año y vuelven a participar y quieren participar. Y cuando tienen algún problema, ellos mismos son los que proponen las soluciones. Así que realmente ese es el primer pilar. El segundo, obviamente, es la organización, que es extraordinaria, que es muy amplia, la organización científica que ocupa desde la Humberto Veronesi Academy, el apoyo de la Fundación Humberto Veronesi en Milán, el apoyo institucional, el apoyo científico de profesores del Instituto Europeo de Oncología y obviamente la Universidad de San Diego, California. Y la parte tecnológica, que realmente es, ya no tengo palabras porque realmente me hacen grandes positivos comentarios de todo el mundo por la eficiencia de la parte técnica, a partir de, bueno, el director general, que es el doctor Darío Cordenons, y la coordinación y dirección técnica y en el campo de batalla de Alexander, que es un maestro para dirigir la orquesta. Y realmente, bueno, obviamente que la parte científica y técnica, porque hacen las dos partes, Karina y Darío, realmente sin ellos nos perderíamos. Y finalmente el tercer pilar son los médicos participantes, porque ¿qué sería de este curso con los mejores speakers y la mejor organización sin 1.200 personas o 1.400 personas en cada momento? Por tanto, y eso se debe exclusivamente a la avidez que caracteriza al médico latinoamericano, a avidez científica, el querer siempre conocer y aprender nuevas novedades. Entonces, para terminar, espero que puedan disfrutar y que aprovechen de este curso. Muchas gracias.
Gracias, Gabriel. Vamos directamente, si les parece, a comenzar el curso, siendo pasadita a las 9:15. Tengo el honor de presentar al doctor Vicente Martínez de Vega, que es director de la División de Imágenes Diagnósticas del Hospital Quirón, Madrid, España, aparte de ser un gran amigo y un excelente orador. Así que nos va a hablar de resonancia de mama, claves para decidir qué lesiones conviene biopsiar. La moderadora, después le dará la pregunta, va a ser la doctora Karina Pesce. Vicente, te dejo ya que compartas y es todo tuyo.
Muchas gracias, mucho ánimo te mando. Muchas gracias también, Karina y Gabriel, y bienvenidos a todos. Vamos a comenzar esta charla que va a versar sobre las claves que nos van a permitir decidir qué biopsias biopsiar cuando hacemos una resonancia de mama. Como sabéis, la resonancia de mama tiene una altísima sensibilidad para diagnosticar el cáncer invasivo de mama, cercana al 90%, al 99%, y su especificidad ha mejorado mucho en los últimos tiempos también. Hay algunas indicaciones muy establecidas para indicar resonancias de mama, estadificación en el caso de cáncer diagnosticado, cribado en pacientes de alto riesgo, incluso recientemente también en mamas densas tipo D, en el seguimiento de quimioterapia neoadyuvante o en caracterización de casos seleccionados. Debido a esa alta sensibilidad, vamos a encontrarnos lesiones sospechosas en resonancia magnética que no se ven con ecografía ni mamografía, y esto nos da un problema, con lo cual tenemos que saber bien cuáles son los criterios que vamos a utilizar para decir si una lesión que vemos en la resonancia de mama es sospechosa o no. La resonancia de mama nos aporta tres tipos de información. Uno es el morfológico, como es la morfología de las lesiones. Otros son las curvas de captación, las famosas patrón cinético de captación de las lesiones. Y el otro es la difusión. Cuando vemos una lesión en mama, que inicialmente no se ha visto mamografía ni ecografía, y aquí os pongo un ejemplo. Esta es una paciente que tiene un cáncer probado en cuadrante superosterno mediante ecografía, y al hacer una resonancia de estadificación se le vio una lesión en cuadrante inferosterno que inicialmente no había sido vista. Tenemos que analizar si esa lesión es sospechosa o no. ¿Y en qué nos vamos a basar? Pues nos vamos a basar en lo que hemos contado, en las curvas, en la morfología, en la difusión, y también vamos a meter una cuarta variable, que es considerar si esa paciente es de riesgo o no es de riesgo, porque en esas pacientes, como veremos, somos más agresivos. Este caso que acabo de demostrar, la lesión que no había sido vista inicialmente, la analizamos, tiene márgenes irregulares, un valor de ADC bajo, una curva tipo 3, y ¿qué es lo siguiente que tenemos que hacer? Pues lo siguiente es una ecografía dirigida a ese cuadrante inferoexterno, ya sabiendo dónde tenemos que intentar localizar la lesión. Esa ecografía que llamamos dirigida o de second look localiza más del 80% de los cánceres invasivos que inicialmente solo son vistos con resonancia. Es decir, que esas ecografías dirigidas la ecografía es la mejor amiga de la resonancia magnética. Es imprescindible una coordinación muy estrecha y un trabajo en equipo con los equipos de ecografía para localizar estas lesiones. En este caso se localizó esa lesión, se biopsió y fue un segundo cáncer infiltrante. En ocasiones, como en este caso, también tenemos una lesión en una paciente de alto riesgo que tiene márgenes irregulares, también tiene una curva tipo 3, es una lesión sospechosa. Le realizamos una ecografía dirigida y la ecografía fue normal. En este caso, con una lesión sospechosa, no nos queda otro remedio que hacer una biopsia guiada por resonancia magnética. El resultado fue un cáncer lobulillar infiltrante. Pero volvamos al principio y vamos a ver qué es lo más importante para decidir si una lesión es sospechosa o no. Vamos a comenzar con la morfología. La morfología es probablemente la clave para decidir si algo es sospechoso o no. Y para esto lo primero que tenemos que hacer ante una lesión que capta contraste es decidir si se trata de una masa o de una captación no masa. Una masa es una lesión que ocupa espacio tridimensionalmente y una captación no masa es una zona de realce que no tiene ese efecto de masa tridimensional. Cuando nosotros catalogamos una lesión que capta como una masa, lo principal, lo que nos va a ayudar a decidir si esa lesión es sospechosa o no, es el análisis del margen, del borde de la lesión. En cambio, cuando tenemos una captación no masa, lo que nos va a decidir si es sospechosa o no es su distribución. En cuanto a las masas, los márgenes pueden ser lisos, bien definidos en toda su extensión, pueden ser irregulares o pueden ser espiculados. Las lesiones con márgenes irregulares o espiculados son más sospechosas que las lesiones con márgenes lisos. En cambio, en los realces no masa lo que vamos a valorar es su distribución. Esas captaciones pueden ser focales, cuando no tienen una distribución ni ductal ni segmentaria y ocupan menos del 25% de un cuadrante de una mama. Pueden ser regionales, cuando ocupan más de un 25%. Después pueden ser lineales ductales. Estos son líneas ramificadas que captan contraste, que siguen ese patrón de los ductos, o pueden ser segmentarias, que es un tipo de captación lineal ductal que ocupa un lóbulo mamario y que suele tener una morfología característica, con esa morfología triangular, con la base posterior y el ápex apuntando hacia el pezón. Este tipo de captaciones suelen ser, se consideran de sospecha. También hay captaciones regionales múltiples o captaciones difusas que son frecuentes en los cambios mastopáticos. Nosotros, cuando analizamos las primeras más de 1000 biopsias que hicimos con resonancia en lesiones que no eran vistas ni con mamografía ni ecografía, analizamos la probabilidad de que una de esas lesiones fuera maligna basándonos únicamente en estas características morfológicas, independientemente de la curva. Y como veis, las masas de márgenes espiculados tienen una muy alta posibilidad de ser un cáncer de mama. Recordar que son lesiones no vistas en mamografía, con lo cual estas masas a las que me refiero habitualmente son de pequeño tamaño, menos de 1 centímetro. Las captaciones no masas segmentarias también tienen una altísima probabilidad de ser malignas, y estas que biopsiamos no tienen microcalcificaciones, porque si tienen microcalcificaciones las biopsiamos con mamografía. También las masas de márgenes irregulares tienen más del 50% de posibilidades de ser malignas, y las captaciones con patrón ductal, esas líneas ramificadas, tienen casi un 50%. O sea que esas lesiones siempre las vamos a considerar de sospecha. Las captaciones regionales o focales tienen alrededor de un 20% de posibilidades, especialmente en pacientes de alto riesgo, o las captaciones lineales con un poco menos del 20%, y de destacar las masas con márgenes bien definidos, apenas el 3%, y cuando son muy pequeñas tienen posibilidades de ser malignas. ¿Cuáles son los aspectos importantes en el análisis morfológico? Bueno, primero, tener una alta resolución espacial cuando hacemos la resonancia. Es clave tener una resolución en plano menos de 1 por 1 milímetros en el tamaño del píxel. Como he dicho, las masas con márgenes espiculados o irregulares deben ser consideradas de sospecha independientemente del tipo de curva. Las captaciones no masa con morfología segmentaria o ductal también deben ser consideradas de sospecha y biopsiadas. Y las lesiones con bordes totalmente definidos, pues inicialmente no deben ser consideradas de sospecha. Y sobre esto quiero hacer un apunte. El fibroadenoma es una lesión que nos vamos a encontrar en muchísimas resonancias de mama, y entonces es importante identificarlos para no realizar biopsias innecesarias. Una clave para diagnosticarlos son la presencia de septos hipointensos dentro de la lesión. Esos septos son líneas que no captan contraste y que traducen la existencia de bandas de colágeno dentro del fibroadenoma. Esos septos son muy característicos. A veces se ven en los fibroadenomas mixoides, que son hiperintensos en T2, los podemos ver también como líneas hipointensas. Como digo, son muy frecuentes y en las lesiones se pueden ver como esas pequeñas líneas hipointensas que veis en esos nódulos que no captan contraste. Cuando un nódulo tiene esta línea, ese es un signo muy específico de fibroadenoma. En cuanto a las curvas de captación, pues tenemos dos partes que analizar. Por un lado, está los 2 primeros minutos tras introducir contraste. La mayoría de los cánceres captan de forma muy rápida en esos 2 primeros minutos. En el primer minuto especialmente suelen realzar más del 100%. Y después analizamos la parte tardía de la curva, lo que pasa después de los 2 minutos. Aquellas lesiones que pierden contraste, que lavan, que tienen la llamada curva tipo 3, suelen ser de alta sospecha, mientras que las de tipo 1 son más frecuentemente benignas. Cosas importantes a destacar en las curvas. Es muy importante que la resolución temporal sea corta, cuanto más corta mejor. Si es de 1 minuto o menos, por adquisición 3D, mejor. Como decía, más del 95% realzan de forma intensa en el primer minuto. La curva tipo 3 es más específica, pero algunas lesiones benignas, fibroadenomas, papilomas, adenopatías, pueden tener esta curva tipo 3, o sea que cuidado con esto. Las curvas tipo 1 o 2 pueden estar en lesiones benignas y malignas. Aquí tenemos un ejemplo de un nódulo que tiene una curva tipo 3 con lavado, pero si os dais cuenta tiene un septo en su interior. Es un fibroadenoma y por eso una lesión de tipo 3 de forma aislada, una curva tipo 3, no debe ser considerada como BIRATS 4 solo por tener esa curva. Hay que asociar otros signos. La difusión es la tercera información que tenemos. Nos da idea de la celularidad del tejido. Lo que hace la difusión es que nos permite medir el desplazamiento de las moléculas de agua en el espacio extracelular y se puede cuantificar en milímetros cuadrados por segundo. Esto lo hacemos mediante un ROI y nos mide el ADC, el coeficiente de difusión aparente. En el cáncer de mama, que tiene muchas mitosis y el espacio extracelular es pequeño, las moléculas de agua no se pueden desplazar, la difusión está restringida y generalmente en los cánceres la difusión, el ADC es menor de 1,3 por 10 elevado a menos 3 milímetros cuadrados por segundo. Y esto tiene una muy alta sensibilidad y especificidad. Pero hay algunos aspectos que quiero destacar. El número 1 es que solo se debe analizar con difusión las lesiones que captan contraste, porque hay muchas cosas que pueden tener la difusión baja, por ejemplo, el tejido graso, los quistes con contenido proteináceo hemorrágico, que son muy frecuentes en resonancia en la mama, y por eso solo analizar lesiones que captan contraste. Es muy útil en las lesiones que captan contraste tipo masa y menos útil en las no masa. ¿Por qué? Pues porque se entremezcla a veces en los cánceres in situ tejido tumoral con tejido normal o con grasa que tiene, como os decía, la difusión baja, el tejido fibrogranular, la difusión alta. También es importante no analizar lesiones muy pequeñas por volumen parcial. Por ejemplo, si el grosor de corte de la difusión es de 3 milímetros, comenzaremos a analizar lesiones mayores de 6 milímetros. Y es importante también conocer que hay falsos positivos y falsos negativos. Hay lesiones hipercelulares benignas que van a tener un valor de ADC bajo similar al cáncer, como los papilomas, ganglios intramamarios, abscesos también pueden tener un ADC bajo. Y hay falsos negativos, algunos cánceres que tienen el ADC alto, como el cáncer coloide, el cáncer que tiene una necrosis central, algunos cánceres lobulares, etc. Un cuarto factor que quiero resaltar es la existencia, el caso de las pacientes de alto riesgo. Esto va a influir a la hora de decidir hacer una biopsia, vamos a ser un poco más agresivos. Y estas pacientes pues son, por ejemplo, la que tiene ya un cáncer de mama y le vemos una lesión adicional, pacientes con riesgo genético de cáncer de mama o con fuertes antecedentes de cáncer de mama o de ovario, las pacientes que recibieron irradiación mediastínica previa por un linfoma de Hodgkin o una paciente previamente operada de cáncer de mama que tiene más riesgo de desarrollar un segundo cáncer. Este es uno de los ejemplos que os voy a mostrar, una paciente que venía por otra lesión en la mama izquierda y que en la mama derecha se ve una pequeña masa, como veis, con márgenes espiculados, tiene una curva tipo 1 y un valor de ADC bajo. Esta lesión, simplemente por el hecho de los márgenes espiculados, ya es sospechosa, por lo cual la biopsiamos y fue un cáncer ductal infiltrante de tipo 1. Esta paciente es curiosa y es un ejemplo de la utilidad de la resonancia. En una mamografía se le vio una distorsión aquí abajo, cuadrante inferointerno de la mama derecha, se biopsió con mamografía, fue un carcinoma ductal infiltrante y a pesar de ser una mama grasa hicimos porque en nuestro centro hacemos estadificación a todas las mamas y se vieron dos lesiones adicionales, una en cuadrante superoexterno de la misma mama, muy periférica, de tipo masa con márgenes irregulares y una captación focal muy pequeñita en la porción central de la mama izquierda. Sobre la misma mama derecha que teníamos el cáncer, esta es el cáncer ya biopsiado. Decir que todas las lesiones tenían curva tipo 1 y sobre la lesión adicional que encontramos en cuadrante superoexterno de la mama derecha hicimos una ecografía y vimos esa alteración que se biopsió y resultó un carcinoma ductal infiltrante grado 1. En la mama izquierda, con la ecografía dirigida, no vimos ninguna lesión, por lo cual se decidió en comité hacer una biopsia de esa pequeña lesión con resonancia y el resultado fue un carcinoma ductal in situ. Este es el último ejemplo que os quería poner, una paciente con fuertes antecedentes familiares, se había puesto unos implantes estéticos, con una mama muy densa, mamografía y ecografía normales, y como vemos tiene alteraciones en las dos mamas. En la mama izquierda le vimos una masa por debajo del nivel del pezón que tenía márgenes irregulares, una captación heterogénea en anillo de alta sospecha y además tenía una captación regional muy amplia que ocupaba prácticamente cuadrantes internos y zona central de la mama, que tenía una curva tipo 1. La lesión, la masa, se localizó con ecografía, se realizó una biopsia y resultó un cáncer ductal infiltrante grado 2 y sobre la captación regional que no tenía microcalcificaciones realizamos una biopsia con resonancia y fue un carcinoma ductal in situ. En la mama derecha veíamos una captación ductal segmentaria en cuadrantes inferiores con curva tipo 1 y se decidió hacer, por la alta probabilidad de malignidad, también una biopsia con resonancia. El resultado fue un carcinoma ductal in situ. Y como conclusiones, decir, ¿qué lesiones vamos a biopsiar? Pues las que tienen captación de tipo masa, mayor de 5 milímetros, con signos de sospecha, es decir, márgenes irregulares o espiculados o captación en anillo con márgenes irregulares. En las captaciones masa que tienen un borde no totalmente bien definido y tienen curvas 2 o 3, va a entrar el factor de pacientes de riesgo. Si es un nódulo adicional en una paciente con cáncer de mama o tiene riesgo genético, en estos casos de alto riesgo vamos a biopsiar. En cuanto a las captaciones no masa, toda captación ductal o segmentaria sin microcalcificaciones va a ser biopsiada, y las captaciones focales o regionales muy asimétricas en pacientes de alto riesgo también las vamos a biopsiar. Esto independientemente del tipo de curva de captación. Otras lesiones las vamos a controlar. Por ejemplo, las masas con bordes totalmente bien definidos en pacientes de riesgo, les vamos a hacer una ecografía, y si la ecografía es sugestiva de fibroadenoma, las vamos a seguir con ecografía. Las captaciones lineales también las vamos a controlar, o las captaciones focales o regionales en pacientes que no son de riesgo. ¿Y qué lesiones no vamos a biopsiar? Pues las lesiones, las masas que tienen bordes totalmente bien definidos, especialmente si tienen septos hipointensos, porque ese es un signo muy específico de fibroadenoma. Las lesiones menores de 5 milímetros, esos captaciones puntiformes, focales, eso, por favor, no les midáis la curva, porque en muchos casos van a ser 3. Las captaciones menos de 5 milímetros hay que considerarlas normales, no se deben biopsiar. Las lesiones que tienen tejido graso en su interior, las necrosis grasa, los amartomas, esas son lesiones benignas, y las zonas de realce no masa que no tienen patrón ductal o segmentario, si no tienen riesgo las pacientes, tampoco las vamos a biopsiar. Y esto era todo lo que quería compartir con vosotros en el tiempo que he tenido. Muchas gracias.
Gracias, Vicente, excelente como siempre, la verdad que clarísimo, cada diapositiva era para tomar un montón de conceptos. Y en base a lo que presentaste te quería preguntar, aquellas lesiones que solamente se ven en resonancia magnética nuclear, ¿qué porcentaje de malignidad encuentras en tu práctica diaria en las biopsias por resonancia?
Bueno, en la estadística que tenemos en mi centro, que tenemos más de 2.500 biopsias ya realizadas, aproximadamente el 37% fueron malignas, muchas de ellas carcinomas in situ. Muchas las biopsiamos, es verdad, en pacientes de alto riesgo, porque hacemos mucho screening de alto riesgo y estadificación, entonces encontramos lesiones adicionales. El 37% es un porcentaje superior al que recoge la literatura, que está en torno al 20-25%, porque también lo hacemos en pacientes muy específicas y bueno, cuentas con experiencia que te ha enseñado a lo largo de los años a que algunas lesiones no hay que ser muy agresivo con ellas.
Excelente. Sí, obviamente en manos altamente entrenadas como vos, Vicente. Tengo una pregunta porque es algo que nos pasa en la práctica diaria, que nos derivan pacientes para realizar resonancia magnética nuclear porque tienen una asignación BI-RAD 4 en mamografía o en ecografía y envían para hacer la resonancia magnética para definir. ¿Qué pasa en aquellos casos donde la resonancia es negativa? Entiéndase, no hay ninguna captación a nivel de la resonancia. ¿Te da igual que la indicación haya partido de microcalcificaciones, distorsión en mamografía o que sea un nódulo o una lesión no masa en ultrasonido?
No, es diferente, es diferente. Si la captación es una masa y o es una distorsión mamográfica y no capta contraste, nosotros no le hacemos biopsia porque, bueno, pues no hemos encontrado lesiones que no capten contraste y sean malignas. El caso diferente, por ejemplo, y bastante habitual, es una captación no masa, una distorsión que aparece como un realce no masa con realce tenue en resonancia. Bueno, habitualmente esto se correlaciona porque cuando es un cáncer tiene los criterios de cáncer, márgenes irregulares, realce precoz, difusión, pero cuando es una captación no masa con un tenue realce, muchas veces esto correlaciona con cicatrices radiales, como se espera también encontrar en mamografía. En ese caso sí hacemos biopsia. La hacemos habitualmente por mamografía, que es más barata, y eh, la hacemos porque en ocasiones, en pocos casos, pero en algunas ocasiones encontramos carcinomas in situ asociados y no puedes excluir esa posibilidad. El tema de las microcalcificaciones es diferente. Las microcalcificaciones deben ser catalogadas exclusivamente con mamografía. Si tiene criterios mamográficos de BIRATS 4, deben ser biopsiadas incluso si la resonancia es negativa, porque es verdad que la mayoría de los cánceres in situ, más del 90%, captan contraste, pero hay un 10% que no, y entonces no podemos excluir. De todas formas, en este caso la resonancia tiene mucha utilidad porque la extensión del cáncer medida con resonancia ajusta mucho mejor a la anatomía patológica que las microcalcificaciones. Es decir, solemos encontrar cáncer fuera de los límites de las microcalcificaciones. Por eso es importante estadificar las microcalcificaciones positivas con una resonancia. O sea que sí y no, las distorsiones que no captan no las biopsiamos porque no hemos encontrado cáncer en esos casos, pero si la distorsión capta, sí vamos a biopsiar, y las microcalcificaciones las catalogamos para su biopsia o no con mamografía.
Perfecto. Y si las microcalcificaciones biopsiadas te dan un carcinoma ductal in situ, ¿haces alguna disquisición en el momento de pedir resonancia de acuerdo a los distintos subtipos o
No,
le pedís a todos, bajo grado, alto, intermedio o alto
no,
grado?
le pedimos a todos porque nos hemos encontrado también cosas interesantes, que es, además de la mayor extensión del tumor, nos hemos encontrado focos infiltrantes en otra zona sin microcalcificaciones. Y eso te marca un poco el ganglio centinela, te marca un poco la cirugía. No es lo mismo biopsiar un grupo de microcalcificaciones de 8 milímetros que te va a dar un cáncer in situ y no vas a plantearte ganglio centinela, a hacer una resonancia, ver que el cáncer in situ mide 4 o 5 centímetros, que ya te vas a plantear un ganglio centinela, o que incluso tiene alguna zona donde no hay microcalcificaciones y tú estás viendo que hay una captación de tipo masa que podría ser un infiltrante.
Excelente. Me quedaría toda la mañana, pero tenemos que ser respetuosos para el próximo orador. Muchísimas gracias, Vicente. Te vamos a tener en
Gracias a
marzo
vosotros.
próximo y en Argentina en junio. Gracias, un placer como siempre.
Gracias,
Vamos,
Vicente. Abrazo grande.
Abrazos,
gracias.
Darío.
Vamos a presentar al próximo conferencista, que es el doctor Gabriel Farante, que forma parte de la División de Cirugía del Instituto Europeo de Oncología, es director de la Humberto Veronesi Academy y nos va a hablar sobre carcinoma ductal in situ de bajo riesgo, tratamiento versus observación, y el moderador va a ser el doctor Andrés del Castillo de Córdoba, un gran amigo. Bueno, dejo de compartir para dar lugar al doctor Gabriel Farante. O'clock te entregamos, Gabriel.
Entonces, la introducción a este tema, que es un tema simple, hoy vamos a escuchar, como el que acabamos de escuchar, temas muy importantes, muy decisivos en el tratamiento, en el diagnóstico del carcinoma ductal in situ, pero este es algo más simple, pero se trata de un ángulo del área que todavía no está resuelto, porque todos sabemos que el carcinoma ductal in situ puede progresar a cáncer de mama infiltrante, pero la mayoría de las lesiones de DCIS permanecen indolentes, no infiltran, no producen un staging. Sin embargo, el tratamiento convencional recomienda la cirugía y a menudo complementada con radioterapia. Esto implica un tratamiento excesivo del DCIS indolente, un sobretratamiento. Pero aún no hay una respuesta ni una solución definitiva a este problema. Sabemos que la incidencia del carcinoma ductal in situ ha aumentado 8 veces desde el 80 al 2007, obviamente por la aparición del screening mamario. El DCIS representa hasta un 25% de todos los cánceres de mama en la era del screening mamográfico, 1 de cada 4 diagnosticados. Y también los datos del SER, que es el organismo americano Surveillance Epidemiology and Results, que indican que la tasa actuarial de mortalidad específica por cáncer de mama 20 años después del diagnóstico, el DCIS, es solo del 3.3%. Y la radioterapia adyuvante no presenta ningún beneficio significativo sobre la mortalidad. Existe una parte importante de la comunidad científica internacional que trabaja e investiga sobre el manejo del DCIS. Prácticamente en el cuerpo de la presentación voy a presentar los grandes grupos internacionales que se están dedicando en este momento, y qué es lo que hace cada uno, a el tema del manejo del DCIS. En primer lugar, el The Grand Challenge Precision Consortium, que es un grupo de instituciones, institutos y hospitales de Gran Bretaña, Holanda y Estados Unidos. El estudio dirigido por la Martínez Legac en la Sorbona de París. El estudio del Netherlands Cancer Institute en Ámsterdam, Holanda. Y los 4 trials randomizados que estudian la observación con vigilancia activa, el COMET, LORIS, LORETA, que se van a concluir con la presentación de qué es lo que aporta el Instituto Europeo de Oncología, nuestro Instituto Europeo de Oncología, en este campo del manejo general del DCIS, sobre todo de bajo riesgo. En primer lugar, entonces decía, el grupo de Grand Challenge Precision Consortium, que es una iniciativa internacional y multidisciplinaria creada en 2017, formado por instituciones, investigadores, médicos, cirujanos de Gran Bretaña, Holanda y Estados Unidos. Sobre todo la Cancer Research de Gran Bretaña, universidades de Cambridge, y luego en Holanda la Universidad de Netherlands, el Medical Center de Leiden, y en Estados Unidos diversas instituciones a partir del MD Anderson de Houston. ¿Cuáles son los objetivos de este consortium? Es obtener nuevos conocimientos sobre la progresión del carcinoma ductal in situ a infiltrante, ese camino que va del ductal in situ hacia el infiltrante. Desarrollar herramientas de estratificación de riesgo que puedan predecir si una mujer con diagnóstico de DCIS desarrollará un cáncer de mama infiltrante. Generar e integrar datos clínicos, genómicos, patológicos, epidemiológicos de gran cohortes y grandes números de pacientes. Cuarto, reducir el sobretratamiento por DCIS. Quinto, definir criterios para distinguir mejor entre el DCIS de alto y de bajo riesgo. Los estudios, el tercer estudio es el de la Universidad de la Sorbona de París, de Martínez Legac y su grupo, que son ginecólogos, que estudió exactamente en la revisión fue una revisión exhaustiva de la literatura, donde identificaron 265 artículos retrospectivos, un metaanálisis, buscando variables, características más frecuentemente asociadas con el riesgo de subestimación del carcinoma infiltrante. Ellos vieron 265 artículos, por tanto tuvieron que extraer las principales conclusiones, que fueron que las variables más encontradas y significativas fueron la presencia de una lesión palpable, la presencia de alto grado G3 a la core biopsy y la presencia de una masa mamográfica. El tamaño de la lesión debería ser al máximo de 20 milímetros. El otro estudio, el de Netherlands Cancer Institute, que se profundizó sobre los predictores de los factores predictivos de un cáncer invasivo de una recurrencia invasiva después de un DCIS. Y se realizaron una sistemática review con el metaanálisis. Participaron las divisiones de patología molecular, la de patología, la división de psicosocial, de investigación psicosocial y epidemiológica. ¿Qué es lo que realizaron? Analizaron 1.781 artículos del PubMed, que es la base de datos. El tamaño de la muestra de los estudios debería ser incluir entre 52 y 37.692 pacientes. El tiempo medio del seguimiento fue de 3,2 años y 15,8 años. Todos los pacientes diagnosticados con DCIS fueron entre el 60 y 2010. Solo 40 papers de estos 1.781 fueron seleccionados, porque este bajo número fue debido a que solo 40 cumplieron con los criterios de inclusión, números mínimos de pacientes, al menos un año de follow-up. Solo unos pocos estudios se centraron específicamente en la recurrencia del cáncer infiltrante después del DCIS. El resto, ¿qué pasó con el resto de los 1.781 artículos? Lleno de discrepancias, datos diversos, fuentes diversas, muy heterogéneas, grupos estudiados muy homogéneos, no homogéneos. Entonces, cada estudio tenía características distintas. A algunos les faltaba estudiar la recurrencia si era in situ o invasiva, a otros si tenían, eran de microinfiltración adyacente o microinvasión, etc. Había una deshomogeneidad completa entre los datos. Por eso que se limitaron a 40. Y entonces, el objetivo de esta revisión fue doble. En primer lugar, identificar factores pronósticos con asociación estadísticamente significativa con casos de cáncer infiltrante posterior al DCIS que se merezcan validación. 17 estudios evaluaron 26 factores, de los cuales 6 eran pronósticos. Los factores asociados estadísticamente significativamente con el riesgo de infiltración posterior al DCIS en los metaanálisis dieron como resultados que fueron los siguientes. La raza afroamericana, porque había muchos de estos estudios sobre el DCIS que eran norteamericanos. El segundo, el estado premenopáusico. Tercero, la detección por palpación. Cuarto, los márgenes positivos. Quinto, el alto grado histológico. Y sexto, la alta expresión de Pesce 16. La asociación entre los 6 factores de pronóstico desfavorable y el riesgo posterior de carcinoma infiltrante puede explicarse biológicamente, como lo han demostrado diversos trabajos. En segundo lugar, dar una idea del riesgo de sesgo, desvíos, errores que se introdujo con frecuencia en los estudios de factores de pronóstico de recurrencias con infiltración posteriores al DCIS. Causas del mayor riesgo de sesgos en los estudios fue atribuible a una insuficiente medición, a un manejo de factores de confusión, a grupos de estudio mal descritos o mal diseñados. Y en cuarto lugar, tenemos que analizar y ver lo que nosotros ya conocemos y que es el tema más actual en este ámbito, que son los estudios de vigilancia activa, o sea, de cirugía versus vigilancia activa o cirugía versus observación. Esta es una estrategia de gestión alternativa para el DCIS y en lugar de una cirugía inicial con posible radioterapia, las pacientes se someten a un cercano seguimiento mamográfico o con resonancia magnética y pueden recibir tratamiento hormonal, por ejemplo, tamoxifeno o inhibidores de la aromatasa. Este enfoque pretendía ser paralelo a los cambios en el tratamiento del cáncer de próstata en edad temprana, lo cual demostró que una terapia más agresiva no siempre necesariamente mejora la mortalidad a costa de la morbilidad. ¿Cuáles son los ensayos de vigilancia activa? Son conocidos por todos ustedes. Hay 4 ensayos multicéntricos diseñados para determinar qué lesiones de DCIS están asociados a un riesgo futuro de carcinoma infiltrante. Los más conocidos son son Loris, Lord, el Comet y Loretta, que describimos a continuación. Bueno, aquí están las características generales, que esto se conoce ya de 4 o 5 años atrás. Los grupos Loris de Gran Bretaña, Lord de Holanda, el Comet de Estados Unidos y Loretta de Japón, y la descripción del diseño general son todos randomizados, salvo el último, el japonés, que es un ensayo confirmatorio de un solo brazo. El tamaño de las muestras de destino que deben alcanzar cada grupo, el resultado primario que que busca la supervivencia libre del cáncer de mama invasivo ipsilateral a 5 años uno, a 10 años otros, a 2 y 5 años el tercero. Entonces, la edad, que más o menos es homogénea, 46, 45, 40, el grado nuclear, que es prácticamente el mismo, salvo el Lord, que toma solamente el G1, el estado del GER, que es homogéneo, y el tamaño del tumor también, que es homogéneo. ¿Cuál es la situación de estos 4? Hasta aquí más o menos conocemos los detalles, pero ¿cuál es la situación actual de estos 4 estudios? El LORIS, en primer lugar, es el estudio británico, es un estudio diseñado inicialmente como ensayos controlados randomizados que tuvieron dificultades en la desinscripción debido a un pobre reclutamiento. La situación actual, ¿cuál es? Que ha detenido por completo el reclutamiento. El estudio LORD de Holanda, que es un estudio diseñado inicialmente como ensayos controlados, randomizados, también tuvo dificultades en la inscripción. Por ello, la situación actual es que ha detenido la randomización, no el reclutamiento, la randomización, pero permite que las mujeres se inscriban y decidan qué tratamiento seguir, si cirugía convencional o vigilancia activa, si cirugía convencional versus la observación. La situación actual, en cambio, del COMET, que es el estudio americano, que es la comparación del tratamiento convencional versus terapia médica endocrina para el trial randomizado para pacientes con DCIS de bajo riesgo, con sede en Estados Unidos, que es un ensayo de control randomizado que compara la vigilancia activa al tratamiento convencional para DCIS. La situación actual de este estudio es que está reclutando activamente. Finalmente, el japonés Loretta, estudio confirmatorio de un solo brazo con un solo tratamiento endocrino. Este estudio está reclutando activamente. Un dato reciente de hace 2 o 3 meses que publicó el grupo del estudio holandés LORD, que dio una información general de la situación actual de los pacientes que habían reclutado. De 377 mujeres reclutadas, el 76% eligió vigilancia activa y el 24% tratamiento convencional. Esto es algo muy interesante, es una novedad que estamos ofreciendo a pacientes de no tener ningún tratamiento para una determinada enfermedad que hasta el día de hoy todos se operaban, y este grupo, el 76% de las participantes eligió la vigilancia activa. El ensayo LOR es el primero en ofrecer a las mujeres con DCIS de bajo riesgo la posibilidad de elegir entre el tratamiento convencional y la vigilancia activa. La mayoría de las mujeres optaron por vigilancia activa y reportaron altos niveles de confianza en la seguridad de la misma. Sus preferencias resaltan la necesidad de establecer la seguridad de la vigilancia activa para el desarrollo para el DCIS de bajo riesgo. Finalmente, vamos a presentar cuál es el aporte del Instituto Europeo de Oncología en este campo. Es decir, si bien el instituto en sí mismo no se dedica full time en el cáncer de mama, a este tema, sin embargo, ha realizado aportes y está realizando aportes significativos. El primero de ellos es un trial randomizado con tamoxifena a bajas dosis, 5 miligramos por día por 3 años, para prevenir la recurrencia en neoplasia in situ de mama. El follow-up con un follow-up de seguimiento de 10 años. El segundo trabajo, una extirpación completa de la lesión mamaria como guía en el manejo de pacientes con carcinoma ductal in situ. Y en tercero, el estudio retrospectivo de pacientes con DCIS de bajo riesgo en el Instituto Europeo de Oncología de Milán entre el 2009 y 2019. El primero de ellos es un estudio que en realidad comenzó hace 10 años y acaba de publicar durante este año 2023 los resultados a 10 años de follow-up de un estudio que se realizó con tamoxifeno de 5 miligramos a bajas dosis por 3 años. En 500 pacientes con neoplasia intraepitelial mamaria, de las cuales el 20% eran hiperplasia ductal atípica, el 11% un cáncer lobular in situ y el 69%, casi el 70% ductal in situ. La dosis era, como dije, de 5 miligramos por día por 3 años, o placebo versus placebo, y después de la cirugía con o sin irradiación. El criterio de valoración principal fue la incidencia del cáncer de mama infiltrante o DCIS. Los resultados fueron que la edad media al inicio del tratamiento fue de 54 años. El 58% de las participantes eran posmenopáusicas. La mediana de seguimiento fue de 9,7 años. Se diagnosticaron 66 cánceres de mama, 15 in situ y 51 infiltrantes. 25 en el grupo de tamoxifeno y 41 en el grupo placebo, con un P de 0,03. La mayoría de las recurrencias fueron infiltrantes en un 77% e ipsilaterales en un 59%. El cáncer de mama contralateral se presentaron 6 eventos en el grupo de tamoxifeno y 16 en el grupo de placebo, con un P de 0,025. Hubo una reducción significativa del 50% de la recurrencia con tamoxifeno en su grupo de DCIS, que representa el 70% de la población general participante. No hubo diferencias, en cambio, en eventos adversos graves durante el follow-up. La conclusión de este estudio, que fue, repito, publicado en el Journal of Clinical Oncology recientemente, este mismo año, es que el tamoxifeno a 5 miligramos por día, por 3 años, previene significativamente la recurrencia del cáncer de mama infiltrante después de 7 años desde la interrupción del tratamiento, sin eventos adversos a largo plazo. El segundo trabajo es más específico del tema que veníamos tratando. Obviamente el tema del tamoxifeno 5 miligramos no está relacionado directamente con el aspecto del DCIS que estamos analizando, del upgrading, de la incidencia mayor o menor de la infiltración, pero tiene que ver con la prevención, porque eso es muy importante, porque después que se diagnosticó el DCIS y fueron operados, se dio 5 miligramos y los resultados fueron muy positivos, como pudimos ver. Volviendo al tema central de nuestra presentación, está más relacionado porque es un estudio de radiólogos y patólogos de Vieo que realizó una biopsia diagnóstica y también terapéutica. Como vamos a ver, estudio dirigido a identificar las características clínicas y específicas del procedimiento biopsia, que identifiquen de manera más segura y precisa el grupo de pacientes en lo que la biopsia diagnóstica también resulta terapéutica, mediante la eliminación de toda la lesión. Estudiaron 2.173 biopsias y con diagnóstico de DCIS de todos los grados, que concluyó que después del VAB, los pacientes con DCIS que mostraban a la mamografía postbióptica, después de la biopsia, una extirpación completa de la lesión en la cirugía sucesiva tuvieron una tasa significativamente menor de enfermedad. La infiltración residual que aquellos con tumores residuales mamográficamente detectables. Por eso que la mamografía postbióptica, cuando era negativa, tenía un 8,2% de tasa menor de enfermedad de infiltración residual, de posibilidades de infiltración residual. Mientras que la mamografía postbióptica positiva tenía un 19%. El tercer estudio es un estudio retrospectivo que estamos llevando a cabo. En realidad lo teníamos prácticamente terminado hace un año cuando decidimos de aumentar, como hay mucha casuística en el instituto, de aumentar la casuística para tener una solidez mayor desde el punto de vista científico en las conclusiones. El estudio probablemente, agregando estos nuevos pacientes, podríamos tener los mismos resultados, pero la solidez, como digo, la solidez científica de las conclusiones son más importantes. En concreto, se basa, bueno, en lo que veníamos hablando, que hay un sobretratamiento y también un sobrediagnóstico del DCIS, y se estudiaron 351 pacientes, todas con tratamiento quirúrgico, cuadrantectomías el 74,5% y mastectomías el 25,5%, con todos los criterios de inclusión elegibles para los 4 estudios de observación que hemos visto, el LORIS, el LOR, COMET y LORETA. Entonces se tomaron todos los criterios de inclusión y todas las pacientes que habíamos operado ya que entraban en estos criterios, entraron en estos 351 pacientes. Obviamente solo microcalcificaciones, menores de 20 milímetros, y la edad era fueron una mediana de 55 años. De los 151 pacientes diagnosticados por core biopsy, todas eran carcinoma ductal in situ G1 y G2. Se observó, porque G1 y G2, recuerden que era la condición para entrar en los 4 estudios, se observó que la tasa general de upstaging y upgrading sumadas era del 23,6%. Y además que de los 351 pacientes, el 18,2% después de la cirugía no presentaba enfermedad residual en la anatomía patológica final. En concreto, de la tasa general de upstaging y upgrading, que es el 23, el 18 fue un upstaging porque presentaron un carcinoma infiltrante. Y el 5,4% fue un upgrading porque pasaron a un carcinoma ductal in situ G3. Por otra parte, un 18% de pacientes que después de la cirugía no tenía enfermedad residual en la anatomía patológica final, es muy importante. ¿Por qué? Porque por una parte las características eran menores, todos tumores menores de 10 milímetros. Eran todos G2 y G1, 24,4% un G1 y 65,6% de G2. En el análisis multivariable se encontró que todas las variables eran predictoras de upstaging, y en este grupo de pacientes, sin embargo, no se encontró enfermedad residual a la anatomía patológica final. Esto significa que nuestro estudio, que es de simulación, muestra que si hubiéramos hecho entrar estos pacientes con DCIS de bajo riesgo, con los mismos criterios de elegibilidad de los trials internacionales de vigilancia activa, habríamos dado un tratamiento inaceptable al 41,8% de las pacientes. Exactamente a un 23,6% un undertreatment, o sea, un tratamiento insuficiente, y a un 18,2% un overtreatment, o sea, un sobretratamiento, un tratamiento excesivo. En el brazo de observación, más del 23,6% de los pacientes con upstaging y upgrading hubieran recibido un undertreatment y estarían expuestos a un alto riesgo de progresión de la enfermedad. Mientras que en el brazo de la cirugía, un 18,2% de las pacientes hubieran recibido un overtreatment porque tuvieron cirugías blancas, cirugías innecesarias, ya que toda la lesión había sido extirpada durante la biopsia diagnóstica y no se encontró ningún tumor residual después de la resección. En conclusión, es que el 23,6% de los pacientes con DCIS, como hemos dicho, sufrieron un upstaging y un upgrading a la anatomía patológica definitiva, y de estos el carcinoma infiltrante representó el 3/4 de todos los casos. Por otra parte, nuestros datos sugieren que la vigilancia activa no está justificada en nuestro estudio retrospectivo, por las razones que hemos presentado. Además, aunque los estudios muestren resultados positivos por ofrecer una de-escalation del tratamiento quirúrgico a pacientes de bajo riesgo, la gran variabilidad entre centros y las grandes diferencias entre las tasas de upstaging en los diferentes estudios publicados hacen que estos resultados se tomen con precaución. Obviamente, se deben establecer nuevos criterios de selección más estrictos para asegurar y garantizar un manejo óptimo y un tratamiento adecuado para cada paciente. La conclusión final es que el carcinoma ductal in situ puede progresar a cáncer de mama infiltrante. Esta es la misma diapositiva con la que he comenzado, porque en síntesis vemos que si bien el carcinoma in situ, como digo, puede progresar a carcinoma infiltrante, la mayoría de las lesiones son indolentes. Le hacemos cirugía, que es un sobretratamiento, pero hasta el presente no hay respuesta ni solución definitiva a este problema. Cuando en el 2011, escribíamos sobre el DCIS, concluíamos que se necesitan nuevos trials para evaluar el mejor manejo, lo que decimos siempre, del DCIS, que todavía en muchos aspectos es complejo y controvertido. 10 años después, en el 2021, volvemos a publicar y decimos y concluimos que es necesario reducir el sobretratamiento actual de algunas pacientes con DCIS y bajo riesgo. Esperamos que dentro de los próximos 10 años podamos dar una respuesta definitiva a estos detalles del DCIS y del carcinoma ductal in situ. Muchas gracias.
Bueno, muy buenos días para todos. Es un gusto estar en este tan importante curso. Felicitaciones al doctor Farante como cabeza de este equipo, al Humberto a Veronesi Academy y bueno, todo el equipo Karina y Darío que hace tanto tiempo trabajan. Gabriel, muy clara, muy precisa tu charla, has abordado todos los temas. Dos preguntas en concreto. La terminología de las lesiones precursoras del cáncer de mama se han ido modificando de acuerdo con las últimas investigaciones y nuevas técnicas de diagnóstico. ¿Crees que se debería volver a replantear un uso generalizado de esos términos, por ejemplo, como lo dijo la doctora Tabasoli, de la neoplasia intraepitelial? Ella lo proponía como una neoplasia intraepitelial, sustituyendo el término carcinoma in situ por el famoso DIN, el ductal intraepitelial neoplasia.
Bueno, sí, es un tema para comentar porque es muy pertinente, porque nosotros en el instituto seguíamos la doctora Tabasoli, una patóloga americana, y el profesor Veronesi, Humberto Veronesi, también estaba de acuerdo, y de hecho él había propuesto el uso en vez del DCIS, el DIN, que era la ductal intraepithelial neoplasia. Lo propuso a la comunidad internacional, algunos autores siguieron esta propuesta, y Veronesi era muy entusiasta de esto. ¿Por qué? Por dos motivos principalmente. Obviamente el más importante es científico. ¿Por qué? Porque decía que más que carcinoma no era infiltrante, entonces no era un carcinoma, ¿no? En su gran mayoría. Y esta palabra carcinoma era la que llevaba, él explicaba mucho de la emoción de la mujer que descubre el cáncer por primera vez, y le tenemos que decir carcinoma ductal in situ, cuando en realidad por el momento no lo es, y como tal no infiltra, y como tal tiene óptimo, mucho mejor el pronóstico. Entonces, por estos dos motivos, él era entusiasta. ¿Qué sucedió? Que después, en realidad, la comunidad internacional no, quizás estaba concentrada sobre temas más determinantes, y definitorios, y no siguió esta corriente, digamos, de opinión. Pero yo creo que si estos estudios los 4 estudios se confirman que al final va a darse, como ya se está dando en la realidad en Holanda, que le vamos a proponer la observación y la vigilancia activa, obviamente. De hecho, si esto se acepta, vamos a tener que cambiar por fuerza la nomenclatura de la patología, porque de hecho vamos a no tratar, no podríamos no tratar un carcinoma. Así que con el tiempo, tarde o temprano, si se logra, si se encuentra una solución a este tema, vamos a cambiar, seguramente.
Excelente, Gabriel. La otra pregunta que te tengo, bueno, interesante todo este dato retrospectivo de estos últimos 10 años, esas 351 pacientes del estudio del IEO, que está pendiente de ser publicado, arrojan esta tasa de upstaging, de upgrading, inaceptable. Como vos comentaste, la verdad que es un porcentaje muy alto para poder ofrecer una vigilancia activa sin cirugía en este grupo de pacientes. ¿Cómo crees que se podría reducir estos porcentajes, así conseguir tasas aceptables para realizar vigilancia activa y no sobretratar o subtratar estas pacientes?
Bueno, este es uno de los dilemas que hemos presentado y que no, hasta el momento no tiene solución. Pienso que gran responsabilidad y un rol importante, hasta el momento lo han tenido, pero creo que podrían tenerlo aún mayormente, son los radiólogos, porque los radiólogos son los que primero diagnostican, y acá tenemos excelentes representantes como el profesor Vicente y Karina y Darío, y ellos son los primeros, y como la evolución de la tecnología también es constante, tanto en el mejoramiento de la imagen de la mamografía, la ecografía, sobre todo la resonancia magnética, en este caso para el diagnóstico va a ser determinante, pero también el radiólogo es de hecho determinante en el tratamiento, entre comillas, el tratamiento, porque cuando logra, como hemos visto, con la VAB, eliminar todo la lesión, de hecho, hasta el momento volvemos a hacer cirugía después del diagnóstico, pero de hecho en el futuro es casi seguro que se terminará, y prácticamente el radiólogo hará parte del tratamiento, hará en tantos pacientes el tratamiento. Y otro rol importante creo que es el de los patólogos, porque en definitiva, mientras el radiólogo es el primero que lo ve, el patólogo es el primero que lo certifica. Entonces, lo que sí que habrá que realizar objetivos, tanto radiólogos como los patólogos, objetivos protocolares muy claros y rígidos y estándar, para que puedan ser no los grandes centros que tienen grandes equipos de patología, pero en cambio en la periferia que todos pueden hacer el mismo diagnóstico, e incluso en algunos casos un doble control.
Muchísimas gracias, Gabriel. Seguimos con Darío y con Karina con el resto del curso de hoy. Muy clara tu conferencia. Muchísimas gracias. Gracias por la invitación.
Gracias Andrés. La verdad que estaba muy interesante, pero bueno, Gabriel, tenemos que cortar para continuar la próxima conferencia. Muchas gracias, Gabriel, también. Fue muy interesante toda la charla y la discusión.
Gracias.
Bueno, vamos a seguir ahora. Voy a presentar al doctor Peter Cordeiro, que es del Servicio de Cirugía Reconstructiva y Plástica del Memorial Sloan Kettering Center de New York, Estados Unidos. Nos va a hablar de reconstrucción mamaria basada en implantes en 2 etapas: manejo, técnica quirúrgica, resultados y complicaciones. Y el moderador de la charla va a ser el doctor Alberto Rancati. Doctor Cordeiro puede compartir pantalla y comenzar su presentación. Gracias por acompañarnos.
The topic of my presentation this morning is two-stage implant-based breast reconstruction, and I'd like to share with you techniques to maximize outcomes and then how to manage complications. I have no disclosures. So I'm going to go through the different steps that you see here, the different techniques for maximizing success, discuss the mastectomy defect, insertion of the tissue expander, how to select the expander, and then the second stage, which is exchange to permanent implant. What I'm going to be talking about are the various techniques for maximizing success in two-stage implant breast reconstruction, and talking about the first stage insertion of tissue expander and then the exchange to permanent implant. So it's very important, the mastectomy defect, you need to deal with the incision, think about the skin envelope, muscle, and fascia. And this is particularly important for the breast surgeon. As a plastic surgeon, I don't do the mastectomies, but I hope that my colleagues will leave me all these different aspects of the mastectomy defect intact. When thinking about incisions, I started out using these oblique incisions many years ago, and I found that at the end of the day, the final result ended up giving me very weird shapes and contours, and I gravitated more towards the almost true horizontal incisions because I think these expand best. And then with regard to nipple-sparing mastectomies, my preference is a periareolar incision with a small extension. Again, because this gives me the most access to the pocket when I'm doing the second stage. What are the requirements for successful expansion? You need very good quality skin, intact pec major, muscle, intact serratus, and intact other fascias. In selecting the expander, you need to think about the defect as being a vertical defect, where the deficit is vertical because we use a horizontal excision of skin, and therefore we need to expand the vertical dimension, not the horizontal dimension. Thus, if it's a vertical deficit, then in order to maximize the vertical expansion, I prefer full height tissue expanders because for a given volume, they expand vertically as opposed to these much shorter and mid-size vertical expanders that do most of the expansion in the lateral dimension. How do we place the tissue expander? This is a concept that became clear to me after a few years of doing this. If you place an expander at the inframammary fold, even though it's a beautiful anatomic shape, as you fill the expander, the pressure increases, the point of maximum expansion travels upwards, and now you're expanding too high in the upper chest. And instead, if you place the expander lower below the inframammary fold, then the point of maximum expansion is in the lower pole of the breast, which is where you need it. So I generally place the expander 1 to 2 centimeters below the inframammary fold, and lower is better, except you obviously do not want to put this in the upper abdomen. How do you select the size? This is, I think we all do this. We measure the width of the chest, the width of the pocket, and then select the size of expander based on that. In making the pocket, I think it's important to think about this as a musculofascial pocket as opposed to total submuscular, because the pec major is up here, serratus is here, and all these layers of fascia constitute a portion of the pocket. So you need to make a musculofascial pocket and think of it just as one pocket and don't start dissecting the individual components, because then the coverage falls apart. Probably the most important step that evolved in my thinking and approach over time was this concept of doing a fasciotomy. So particularly inferiorly, the rectus fascia is a strong band, and then laterally there's some of the serratus fascia. I will usually do through the pocket a fasciotomy in this fascia and release it, put my hand inside, pull forward, because then you know that it's going to expand. And without the fasciotomy, the expansion is all in the superior pole. So it's a very important concept. And if you look at a lateral view, you can see that by doing the fasciotomy, you're entering into the subcutaneous space, releasing the fascia, and then that allows expansion of the lower pole. Without this, it won't expand inferiorly. It'll be an upper pole expansion only. So the fasciotomy is probably the most important step in the first stage. This is what it looks like afterwards, the muscle above, the fascia below, and you should be able to get total coverage to protect the expander. I usually will intraoperatively expand about half the volume of the expander. If the tissues don't look very good, then I'll put in less fluid, but I like to expand early on intraoperatively, and then starting at 2 weeks post-op, I'll expand weekly, and we'll usually be done with expansions within about a month after surgery. So next step, exchange of the tissue expander. I'll usually wait minimum of 2 months after full expansion before doing the exchange procedure. And I'm going to go through the different steps in this procedure in order to maximize your results. I do all this surgery in the sitting with the patient in the sitting position. We tape the head, the arms, sit her up, make sure everything is square, because really this is what she sees when she's standing in front of the mirror. So it's important to get make everything symmetric, adjust the folds in this position. As you can see here, we tape the head, the arms, pad the elbows, sit her up, and this patient has 2 fully expanded expanders. First thing we do will be to go back into the pocket, excise a portion of the scar. And a very important step, I think, is reconstruction of the inframammary fold. Since I've released the fold in the first step, I almost always will place sutures in the inframammary fold, attaching the deep dermis to the anterior chest wall. It's often just the capsule of the chest wall. I don't really like putting sutures in the ribs. And once you've put in your sutures, you now have something that's starting to look like a breast. The pocket is starting to form. And then probably the most important step in this procedure is what I call the circumferential capsulotomy. I release capsule, and not just in limited places and positions, but all the way around. Because in order to get the entire envelope to expand forward, you need to do this capsulotomy. And it's a circumferential capsulotomy, as you see on the left, that allows release of the pocket anteriorly, which is what you're trying to do. That's where we're deficient. And although many textbooks talk about radial capsulotomies increase the horizontal dimension, and it becomes even flatter. So the concept of the circumferential capsulotomy is very important when you're doing the second stage. And once you've released the pocket, you should have your inframammary fold well set, the pocket completely released. And then this pocket, which consists of skin, subcutaneous tissue, muscle, capsule, will then redrape over the implant. And to a large extent, this is what gives you the optimum result. This should start to look like a breast at this point. I put in this photo to remind me to let you know that I always put in drains, because seromas are probably one of the most annoying and difficult problems to deal with after this step. I use sizers routinely, and sizers are very useful because they will give me a good idea of what specific implant to pick. So the sizers get put in, staple the patient is sitting, staple the skin, the patient is sat up, and that allows me to select the implant. And you need to think about the width, the height, the slope of the patient's breast, and then what type of implant to select. And I used to use mostly shaped implants, but now that we've stopped using shaped implants because of the problem with texture, I use only smooth implants, which means they're all round. You can still select your projection and the dimensions with a round implant, and it still works quite well. So you select your implant based on what looks good at this point and fits well in the pocket. I always use drains because seromas will allow the implant to rotate, flip over, and also become a difficult problem later on. So these are the key concepts that I think allow us to maximize results. The skin deficit is a vertical defect. Shaped expanders will tend to become rounded. The tissue expander should be placed low. The fasciotomy is very important in the first step, and I usually overexpand only minimally now. The second step, do the surgery in the vertical position if you can, reconstruct the inframammary fold. The circumferential capsulotomy is an essential step to allow you to properly redrape the envelope, and always use drains. Just a few examples of these are very standard long-term results with skin-sparing mastectomies, unilateral. Obviously, patients with small breasts are best suited to this type of reconstruction. And you can get very good results using these techniques. And you look at the fold remains. And I follow these patients yearly, and even at 20, 25 years out, you'll still have a nicely shaped fold. You'll still have a good contour. Bilateral reconstruction is obviously best suited to implant reconstruction, and it works really well with small-breasted women, as you see here. But even as they get much larger, you can still get very good results. And even in a very large patient like this, which I started out doing only flaps, and I think you can get beautiful results that are long-lasting with the steps that I just showed you. Now, certainly nipple-sparing mastectomy provides the best results, and these are all patients who have nipple-sparing mastectomies. As you see, this is my preferred incision. You see just a very small extension here. The rest of it is hidden with the periareolar incision. You can expand previously radiated patients. She had radiation a long time before her surgery. We did the mastectomy. You can see the lumpectomy scar here. We use that to place the expander. Another radiated patient on the right side, you see her lumpectomy incision, and it very closely matches the opposite side. And I think the results with nipple sparing are hard to beat. And in a young patient like this, you can get really the best results. So those are the techniques that have evolved in my practice over time to maximize results. What about complications, and how do we manage them? So I'd like to share an approximately 3-decade experience with about 4,800 patients and over 7,000 reconstructed breasts. You can see that they were split about half unilateral, half bilateral. And I follow these patients yearly, and immediately post-op at 30 days, we have a database and we go through all the complications on every patient and enter them. So the data is prospectively collected. And what do we learn about complications from a database like this? You can see that with immediate breast reconstruction, native skin flap necrosis is the most common complication. And this, unfortunately, still exists in my practice because I'm dependent on the breast surgeon. But you can see that with immediate reconstruction, you have skin flap necrosis, infection, and seroma being the most common complications. And with delayed reconstruction, obviously, you don't have any skin flap necrosis. What about placement of the expander versus the exchange procedure? You can see the complication rate at the first stage is about 14% versus 3% for the exchange. And again, the reason for the high complication rate at the first stage is because of mastectomy flap necrosis. When looking at radiated patient in the left column and non-radiated on the right, you can see that radiated patients have a higher complication rate than non-radiated, which is what we'd expect. And the majority of these complications tend to be flap necrosis, infection, hematoma. So what do we conclude from looking at this, at the early complication data? First, at the first stage of reconstruction has a higher rate of complications than the second stage. And then patients who have a history of previous radiation have a higher complication than those without. To go through some of the early complications and how I deal with them, if they have a cellulitis, they get admitted. So here's a patient with cellulitis. She gets treated with usually IV antibiotics for about a week, and that will usually resolve. Seromas are difficult to deal with, And ideally, you want to place drains and wait until the drainage decreases to less than 30 cc's per day. And then a vast majority of those patients, once you remove the drains, will not have the seroma problem. But if you have a seroma, this little catheter can be placed in clinic, attached to a bulb, and I usually then leave it in, give them antibiotics until the drainage decreases. As I showed you, mastectomy flap necrosis is the most common problem that I run into. So I'll show you how I deal with it. And I think this is where having a submuscular pocket really does make a difference, because that really protects the expander and the implant. I routinely do submuscular pockets in patients with radiation or who may have radiation. And it's only the occasional patient who has a pre-prec approach where you don't have this layer of muscle. And if you have this sort of limited mastectomy flap necrosis, you can just observe it. So you can see as you go from 1 week out to 6 weeks, the area slowly heals, and we still expand the patient. And if the muscle is there and intact, it's protective. Here's a patient with more necrosis, and you can see that you can wait it out. And I used to really worry about this and go in and excise them, but then you lose a large portion of your skin envelope. Here's a patient you can see with full thickness necrosis of the skin. We've been following her out to 2 months, 3 months. It's almost healed. And all I do with these patients is have them keep it clean, soap and water, and keep it dry. Very important. I don't put any ointments on, and we don't treat them with antibiotics. And eventually it heals. And if I excise the skin here at the first stage very early on, it would be a much worse outcome, and it would be very hard to expand. This is a patient who disappeared for about 30 days. She was a heavy smoker. After 30 days, she was a heavy smoker, didn't come back. And when she came back and saw me months later, this was totally healed. So you need to be patient and just follow the patient, and these will usually heal by themselves. If the necrosis is very extensive, this patient had fairly extensive necrosis and needed to get on with radiation. So in this scenario, in clinic, I will excise the eschar, remove fluid from the expander, close the wound, and then we can re-expand. So this approach, debridement and closure, is not routine, but for the very extensive necroses, as you see here, I bring them back after about 2 months and excise the eschar, close, and then re-expand. Now, fat grafting has been a game changer in salvaging some of the potentially failed implant reconstructions. I'll show you where it's useful. This is a patient who had already an exchange. She had this very thinned out area and kept getting admitted with redness and what looked like infections. I brought her back and I fat grafted that area, and you can see the big difference between before and after. So you can salvage results with fat grafting in this way. Here's a patient who's had a tissue expander. She ends up losing the expander to all this necrosis and infection. This is what it looked like before we had to remove the expander. And here's what she looks like. And in these patients, often the skin is extremely thinned out. It's stuck to the ribs, and they would often need a flap. Now with fat grafting, I will fill out the defects in the chest wall, come back, replace the expander, and we can go from something like this and to salvage. This is the final implant. You can see how good the quality of the skin on the left side where I injected the fat is, even compared to the right side, which did not, where we did not lose the expander. Here's another example, patient with tissue expanders, radiation. She loses the expander, and you can see the horrible quality of her skin once it's healed. So this is where fat transfer, I think, really does help to improve the quality of the skin. You see after 1 graft, after 2 grafts, and then I come back and do a latissimus flap. And although in theory we could have excised all that skin and done a flap, latissimus flaps don't give you that much skin. So I think it still helps to have an improvement of the skin quality by using fat grafting. So here's what she looked like after she lost the expander, and this is her final result. What about nipple necrosis? This is something that I also see, as I said, I'm dependent on the breast surgeon. And in most cases, I found that observation will really end up giving you the best results. So although early on I would rush back in and excise the nipples and areolas and then proceed, there's actually a fair amount of tissue underneath this eschar because it's nipple sparing. And if you leave it alone and let it heal, it doesn't give you a perfect result, but I think it's better than excising the entire nipple and areola with the ellipse of skin. And here are examples of patients with this type of necrosis and what the final result looks like. So the important thing here, again, is to be patient, wait. And as long as you have that healthy muscle underneath, at the end of the day, you end up with pretty reasonable results. And there's more areolar tissue and nipple tissue there than you'd think below the eschar. What about extrusion? This happens occasionally, particularly in radiated patients. And if an implant extrudes, then I think you need to remove the implant. And then most commonly in these cases, because it's a lack of soft tissue envelope, then whatever flap is appropriate becomes the best way to salvage it. So this is a patient who had a terrible radiation injury to her final implant reconstruction, and she certainly would need a flap. So those are the common complications that I deal with in these patients. And as I said, I think doing a submuscular approach will allow you to salvage most of these problems. Thank you.
Thank you, Peter. Wonderful presentation, as always. And I would like to make you two questions. We know you have a great experience with two-stage breast reconstruction. What do you consider the indication for one stage to go direct to implant?
So for one stage, the patient, must want it. I still think that in my hands, two-stage gives a better reconstruction. I'll tell patients that. But if they really want the one stage, if they're a patient from out of state or out of country, I think then the requirements to me are, it needs to be a patient with good quality skin, usually a B or a full B cup breast, minimal to no ptosis, someone that when you put the implant in right away, the envelope is perfect. And obviously the envelope needs to be perfect. So it often depends on which breast surgeon I'm working with. But those are the kinds of patients where I think a one stage is certainly a good option. But it's not that common. Most patients, they've had radiation, they have a large breast, they have a lot of ptosis. I think in those cases, one stage is not a good choice.
And when do you go pre-pecked?
So pre-pecs are almost the same group of patients. They need to have a perfect envelope. If they're doing bilateral, very good symmetry, minimal to no ptosis, small breast, perfect mastectomy flaps. I think in that scenario, pre-pec's a good choice. I usually in that situation will use alloderm to hold the implant in place.
Okay, and the last question, you were a great fan for anatomical implants before the period of we changed to round. What's your experience now reconstructing all your patients with round implants comparing to the anatomical one?
So it's a good question, Alberto, because I, as you said, I was a huge fan of anatomic implants. I was sure that that's the reason I got these good results. So I was terrified to switch to the round smooth implants, but because we decided to just stop using textured implants, we had to go to smooth and therefore round. And surprisingly, the results are just as good. So I actually recently published a paper looking at patients where I remove a textured implant, a shaped implant, replace it with a smooth round. And I have a big series of those patients now because of the whole issue of the BILCL. And the results, when we look at assessments before and after, both surgeons' assessments as well as the patient's assessments, remarkably, the results with the round are just as good or better. And certainly with replacing the textured implant, I can do maneuvers, release tissue, et cetera, to improve the results. So I'm not saying that round is gives you a better result, but it's something that you shouldn't be afraid of. I've been using only round implants for now 5 years, and I think the results using all these steps that I showed you are essentially just as good.
And the expanders are also round, or do you make anatomical expander and their round implant?
So anatomic smooth expander, which are difficult to deal with because they rotate, et cetera. They need to have tabs. And I found that I need to suture at least 3 tabs. And I will usually suture it to the perichondrium, periosteum, so that it's fixed. Then we expand them. Once they're expanded, even if you then lose the tabs, you've got the expansion done. But anatomic, same concepts, just smooth.
Very interesting. Thank you, Peter. Thank you very much for your collaboration with this activity. Bye-bye.
Thank you.
Muchas gracias, Peter. Muchas gracias, Alberto, por el tiempo. Tenemos que continuar. Era muy interesante la charla que tenían entre ustedes. Pero bueno, Cari, ahora seguimos con el programa.
La próxima conferencista es la doctora Kelly Ham. Ella es jefa del Departamento de Cirugía Oncológica de la Universidad de Texas, del Anderson. Va a moderar la presentación el doctor Fabrizio Brenelli, Nuevos Paradigmas en el Tratamiento del Cáncer de Mama. Dejo de compartir para que la doctora pueda hacer lo suyo.
Okay, so hopefully that's in the proper mode for you to see the slides. And my talk is going to be on new paradigms in breast cancer treatment. Thank you for asking me to participate in this course. So just to go over some of the changes in treatment in breast cancer, dramatic changes, obviously, since the initiation of radical mastectomy and then to breast-conserving surgery, but also sentinel lymph node biopsy was introduced and has been a major thing for us in terms of local regional treatments. And then along the bottom of this timeline, what you see is all of these systemic therapies that have been developed over the last 20 to 30 years. And of course, now we have many targeted therapies being introduced. And then another important thing that has been developed over the last couple of decades is molecular subtyping of breast cancers. And so now, and not only for targeted therapies do we need to understand the subtype, but it also impacts our local regional treatments as well, which is what I'll discuss today. So essentially, we have the 5 subtypes of breast cancers listed here. And of course, the luminal subtypes seem to have the best prognosis as compared with the HER2 enriched and the triple negative subtypes. Although with improving systemic therapies in these groups of tumor types, we are starting to see improved outcomes. And then most recently, we've had the description of not only HER2 enriched, but also HER2 low. And this is the current classification is based on HER2 testing with 3+ IHC or ISH positive. However, HER2 low is now being categorized as IHC 1+ or 2+ with ISH negative. And this is an important thing because now we have specific therapies targeting these HER2 negative or HER2 low subtypes. And so the new classification is HER2 positive, IHC 3+, 2+, and ISH positive, HER2 low being IHC 0 to 1, 1+ or 2+, and then HER2 negative being IHC 0. And the other thing that's really changed over the last couple of decades is our approach to the sequencing of therapy. So whereas in the past we were always doing surgery first, and then employing systemic therapies and radiation after surgery, now we commonly use the neoadjuvant approach, where we give the systemic therapy first, and we see downstaging of the primary tumor, but also the regional lymph nodes. Importantly, the pathologic assessment of response is very important for our patient's prognosis. And now we understand that those with residual disease and certain subtypes will need other therapies in the adjuvant setting. So it's very critical that our surgical approach considers the idea that residual disease needs to be identified. So neoadjuvant therapy also can be termed preoperative systemic therapy or induction therapy. So the advantages when we first started using it was converting inoperable patients to operable. Now we know that it increases breast conservation rates in those with larger tumors, and it also decreases the incidence of positive lymph nodes in many patients. It's an excellent research tool to help us compare agents, but also, again, the in vivo assessment of tumor response is very important for us to understand. And importantly, we know that very few patients will have progression of their disease while on systemic therapy. If we look at pathologic response rates after neoadjuvant systemic therapy, this is data from the ACOSOG Z1071 trial that was looking at patients with node-positive breast cancer receiving systemic therapy. And what you see is that the pathologic response is very dependent on the tumor biomarker subtype. So the estrogen receptor positive tumors, we saw about 16% pathologic complete response in the breast, 11% in the breast and axilla, whereas those with HER2 enriched tumors that received both anti-HER2 therapy and systemic therapy, we saw 50% PCR in the breast, 45% in the breast and axilla, and the triple negative 48% in the breast and 38% in the breast and axilla. And of course, this was before we were using immunotherapy in combination with chemotherapy. So what about the surgical resection after neoadjuvant systemic therapy? Well, we know that this allows for optimal pathologic assessment of the breast tumor site and, of course, the regional lymph nodes as well. But how much does this surgical resection contribute to local control in patients who have pathologic complete response? This is a study from our series at MD Anderson where we looked at local regional recurrence-free survival after breast-conserving surgery in patients that had PCR. And so if we look at 751 patients with almost 5 years of follow-up, those that had HER2 enriched disease, 97.4% local control, triple negative 98.6%, suggesting that surgical management or surgical resection of the primary tumor has very little impact. And so what about how can we identify those who have a pathologic complete response in order to maybe decrease the extent of our surgical therapy? Well, if we just look at standard breast imaging with mammogram and ultrasound, it's not very good. It's not very accurate in terms of telling us whether there's residual disease in the breast and, of course, the lymph nodes as well. If we look at different types of MRI, we get a little bit more sensitivity and specificity. FDG PET is another method, but really not sensitive enough and specific enough for us to identify those with residual disease or those with PCR who might not need surgery. So what about using more minimally invasive techniques like needle biopsy? This is something that we've been exploring at MD Anderson, both fine needle aspiration biopsy and core needle biopsy, because if we could use these minimally invasive techniques to evaluate the tumor bed with high accuracy and a low false negative rate, we might be able to identify patients who are exceptional responders to consider safely eliminating surgery. Now, in this setting, we have been defining pathologic complete response as the absence of ductal carcinoma in situ, DCIS, and invasive tumor. So importantly, no evidence of residual DCIS or invasive disease. And so this is data from the initial feasibility trial that Henry Cure led at our center, MD Anderson Cancer Center, looking at fine needle aspiration biopsy and vacuum-assisted core biopsy, or the combination of these different biopsy techniques of the primary tumor site. And importantly, there was only one false negative event, which resulted in a false negative rate of 5%. In this feasibility trial. All of the patients had subsequent surgical resection. So after these promising results, he then started the exceptional responders trial. So this is a trial enrolling patients with T1, T2 tumors. They could have N1 disease, fewer than 3 nodes on ultrasound, HER2 enriched and triple negative, planned for neoadjuvant systemic therapy. And after systemic therapy, they had image-guided core needle biopsy, and they had 12 9-gauge vacuum-assisted core biopsies, and then a specific protocol for evaluation of the core needle biopsy site to look for residual disease versus those that had no evidence of residual disease. If they had no residual disease, they went on to have no breast surgery, but did have radiotherapy. And the primary endpoint was to look at ipsilateral breast tumor recurrence-free survival at 6 months, 1, 2, and 3, and 5 years of follow-up. There are a number of secondary endpoints as well, including how many patients required subsequent biopsies, what were the cosmetic outcomes, and looking at circulating tumor cells and ctDNA. Now, importantly, at this stage, we utilized we enrolled patients only who had less than 2 centimeters of radiographic abnormality following neoadjuvant chemotherapy. And we did that because we know that from the feasibility trial that some patients who look like they had residual disease on imaging actually on surgical resection had no evidence of residual disease. So the feasibility trial, first 6 patients were evaluated at 6-month follow-up, and then there was an expansion phase. 50 patients were accrued through November of 2021. And this is one example of a patient 43-year-old who had triple negative breast cancer and received paclitaxel and adriamycin-based chemotherapy. After chemotherapy, you can see very good response. The area was biopsied. There was no residual imaging or abnormality on the imaging, and she had a pathologic complete response on final pathology. So this shows how the core biopsies are evaluated. We make sure that we remove the clip, the original clip that was placed at the original diagnostic biopsy. And in this case of triple negative breast cancer, the initial tumor size was 2.2 centimeters. After systemic therapy based on standard imaging, the tumor size was 1.5 centimeters with 9-gauge vacuum-assisted 12 cores, stereotactic guided. You can see the pathology specimens here, so quite good assessment of that primary tumor site and pathologic complete response. This is the initial invasive ductal carcinoma, triple negative, and the vacuum-assisted core biopsy showing fibrosis with no evidence of residual disease. The pathologist does evaluate 2 levels from each of the tissue blocks from all of those 12-gauge core biopsies. And so this shows the data from the trial that was recently published. There were 31 patients who had no residual invasive or in situ tumor, and some of them did have targeted axillary dissection. Some had no surgery at all. There was no residual metastatic tumor in the lymph nodes from these patients that had targeted axillary dissection, and they went on to have radiotherapy. Of course, those that had residual disease on the biopsy did undergo breast surgery and standard treatment. Importantly, 7 had no residual tumor identified on core biopsy excision. This shows the planned analysis in terms of ipsilateral breast recurrence-free survival, and you can see excellent results here. And this shows the secondary endpoints, the patient-reported outcomes, looking at decisional regret score, breast cancer treatment outcome using the standardized scale, and the FACT B+4. And importantly, what we saw is that the scores in terms of decisional regret decreased over time. There was high decisional support over time, and very slight difference the patients reported between the affected breast and the contralateral breast. Excellent high quality of life. And this was published in the Lancet Oncology. And you can see, importantly, the interpretation here is that in highly selected patients that have an exceptional response to neoadjuvant systemic therapy, this image-guided vacuum-assisted core biopsy is a good method for determining pathologic complete response. We do need additional prospective trials, but this is very promising, and we've now initiated an expansion cohort as part of this study. So that's the HER2 enriched and triple negative, but what about the luminal subtype? What's the role of neoadjuvant therapy in these patients? Well, we do have some data from trials like the ACOSOG Z1031 trial. Importantly, this was postmenopausal patients, but they did have more advanced stage, clinical stage 2 and 3 disease, strongly estrogen receptor positive with an all-red score of 6 to 8. And patients were randomized to one of 3 aromatase inhibitors for 16 weeks. They then underwent surgery and received adjuvant therapies as indicated by the primary treatment team. So what we learned from this trial is we categorized patients before they received the aromatase inhibitor in terms of what type of surgery they would need. That we had marginal candidates for breast conservation, candidates for mastectomy only, or even inoperable. And then we looked at the surgery that was performed, whether it was breast conservation or mastectomy. And what you can see in these that were marginal candidates, 83% were able to have breast conservation. In these that were thought to be only candidates for mastectomy, 50% were able to have breast conservation. And even some of those patients who were thought to be inoperable had an excellent response and were able to have breast conserving surgery. So we have looked at the local regional recurrence events from this trial. What you can see here is that there are very few local or regional recurrences in the patients. And the characteristics of patients who did have local regional recurrences, we saw some that had lumpectomy, some that had mastectomy. So it was not just those who were downstaged and had a lumpectomy, but occasionally patients with mastectomy had local recurrence as well. We did see some of the patients that had residual disease in the lymph nodes develop local regional recurrence. And importantly, even some of the patients who had a low proliferative index, Ki-67 at less than 10%, did have local regional recurrence. But at 5 years, the cumulative incidence for local regional recurrence was 1.6%. So really quite excellent results with this trial. And this just shows the data on patients who received, all patients versus those who did not receive chemotherapy. And you can see actually very excellent results in terms of recurrence-free survival. And importantly, this approach has been used by many other groups. More recently, this is data published by the West German study group looking at the ADAPT-HR trial. And these are patients who have intermediate high risk, hormone receptor positive, HER2 negative luminal breast cancers. This is a 2-part prospective phase 3 trial. Part 1 was evaluating the prognostic impact of the recurrence score less than 26 and a decrease in Ki-67 after a short course of preoperative endocrine therapy. In the endocrine therapy alone arm, it was not a randomized comparison, but basically if the patient had a suppression or decrease in the Ki-67 after this short run-in with endocrine therapy, they looked at the data and found that endocrine therapy alone gave excellent outcomes. The primary endpoint was 5-year invasive disease-free survival and many secondary endpoints. But this showed non-inferiority for these individuals with clinically or pathologically node negative and node positive disease, recurrence score 12 to 25, and a Ki-67 that was suppressed below 10% versus those that did not, or versus those who had a lower recurrence score. So this approach of doing upfront surgery and then looking at the score afterward may not really give our patients all of the options in terms of reducing the need for mastectomy and maybe less axillary surgery as well. So using an on-treatment assay, looking at the recurrence score and a decrease in Ki-67 proliferative rate may give more options for our patients who have luminal breast cancers. Now, of course, there are some patients who require mastectomy, and especially that's usually what we recommend for the BRCA1 and BRCA mutation carriers. But we're also starting to see many other genes that we can test for in individuals who have a family history and are at higher risk for breast cancer. And so this was an important study that was published recently looking at what is the contralateral breast cancer risk among carriers with different germline pathogenic variants, ATM, BRCA1, BRCA2, CHEK2, and PALB2. And I thought this was important data to show because not all of these individuals will need to have a contralateral mastectomy based on the mutation type. So certainly those with BRCA1 and BRCA2 mutations do tend to have a higher rate of contralateral breast cancers. But some of the other mutation types, this is really powerful data showing that perhaps they don't need to have a contralateral mastectomy despite the fact that they have a pathogenic mutation. Finally, I just want to talk in the last part of this about management of the regional nodes and some of the changes that we've seen with respect to nodal management. So we typically use ultrasound at my institution. It helps us to evaluate the character of the lymph nodes, and we can even do biopsy. We typically will use fine needle aspiration biopsy. It gives a good sampling of the lymph node under direct vision with ultrasound, and the specificity and positive predictive value are excellent. It's much better than a physical exam, which is essentially 50-50 flip of a coin. And we now have a lexicon for categorizing the lymph nodes based on how they appear, the cortical thickness, whether or not there's any disruption of the fatty hilum. And this just shows a publication by my colleague Carissa Lepetros in one of the radiology journals showing this lexicon for morphologic evaluation by ultrasound. And this can be done before chemotherapy or systemic therapy and afterward as well. This is the guidelines recently published by Ontario Health and ASCO regarding the management of the axilla. And this is for patients with stage 1 and stage 2 disease. And what I highlighted here in the red boxes is that, they've separated patients by clinically node negative versus clinically node positive. But on both sides of this algorithm, you can see that axillary lymph node dissection is still recommended for many of our patients. And I think we're starting to see a bit of a change in that because of the breast cancer related lymphedema that patients will unfortunately succumb to with treatment using axillary lymph node dissection. So lymphedema is 1 in 6 cancer survivors will develop lymphedema. It has 2 phases, an early reversible phase, which is helpful if we can find patients at this early phase because it can be, the impact can be reduced. But when it gets to the chronic phase, it's irreversible. So this is a very important thing for us to identify in patients because there are some techniques, the complex decongestive therapy, which can reduce the impact of lymphedema in early stages. But when it's more advanced, we might need to use some of these reconstructive techniques, although they seem to be less effective when it's in that fibrotic stage as well. And we also know, again, I'm going to show you data from the Z1071 trial because that was patients who all had positive nodes before systemic therapy. And when we looked at the nodal basins after systemic therapy, we saw very high rates of pathologic complete response depending on the subtype. And even in the hormone receptor positive, 21% were pathologically node negative. There have been a number of trials looking at whether we can use sentinel lymph node biopsy to evaluate the nodal basin afterward. And remember that residual disease, identification of residual disease is important because we now have different systemic therapies for those patients that are high risk because they still have residual disease after systemic therapy. Well, with sentinel node biopsy, the false negative rates are still relatively high. We can reduce it by using dual tracer technique, but using clipping nodes and identifying the clipped node after the chemotherapy seems to reduce it the most. And so this is something that we promoted from my institution, MD Anderson, the targeted axillary dissection. So that means that we're placing a clip in that biopsy-proven node before chemotherapy, and then making sure that we localize that node and remove it at the time of surgery. And generally, of course, that's done with sentinel node biopsy in addition to removing the clipped node. So we call this targeted axillary dissection. And what we've shown is that you can really markedly reduce the false negative rate down to very, very low when you use this targeted axillary dissection versus sentinel node dissection alone. And so this is something that we promote because it's more precise. But what about those patients who still need an axillary lymph node dissection? Well, there is a technique called axillary reverse mapping that you can do at the time of axillary lymph node dissection. So injecting the dye in the upper arm, and this was described by Suzanne Klimberg, where you can inject technetium in the breast to identify the sentinel nodes draining the breast, and inject blue dye in the upper arm to identify the lymph nodes draining the arm. There are different anatomic variations, and this has been shown by several studies. This is a systematic review and pooled analysis of 5 randomized controlled trials, showing that the arm node detection rate was about 85%. And the lymphedema rate is much lower in those patients who had preservation of the arm node. Axillary recurrence rates were very low in both groups. So this appears to be a method we can use to reduce the rate of lymphedema in our patients who may still require axillary lymph node dissection. So there have been many improvements in both early stage and advanced breast cancer patients. Many new systemic agents have recently been approved, and the main subtypes that we've always talked about, hormone receptor positive, HER2 low, and triple negative, are being expanded. And this is also, we're looking at the subtypes based on blood and tissue profiling. Of course, now we're able to identify those with BRCA mutations who may benefit from PARP inhibitors. We have several other different things that we can identify in the tumor that can help guide therapy. So this is very important. We're, of course, looking more now at tumor heterogeneity, the tumor microenvironment, downstream signaling pathways and other membrane receptors and their ligands. And the immune system is an important component of this, which we're now starting to see the impact of immunotherapy in our patients as well. So I think in the future, breast cancer diagnostics are going to be we'll still need that pathologic biopsy, but we're going to also have molecular tools incorporated more into the initial diagnosis so that we understand the risk of recurrence. We can select the chemotherapy or systemic therapy. We can understand what breast cancer genes are mutated and individual markers that may be of importance to our patients. I want to thank you very much for this opportunity, and I'm happy to answer any questions.
Thank you very much, Dr. Hunt. It's very nice to see you again. Yes. It was a real complete presentation. And I just have one question. We are living now in a new era of the axillary surgery, especially with those new advanced treatments like cyclin inhibitors. How are you managing those patients that are outside of the indications, for example, T2, grade 1 and 2, Ki 60 less than 20%? And if you have, for example, 1 or 2 positive nodes in sentinel lymph node biopsy, do you go for axillary dissection? Do you try to find more nodes? How are you dealing with these cases?
Yeah, so that's an excellent question. I think, of course, you're trying to identify those who might have 4 or more positive nodes who would be candidates for receiving the adjuvant systemic therapy with CDK4/6 inhibitors. And so we're using that ultrasound prior to surgery or chemotherapy to identify the number of abnormal nodes. And so our radiologists do help us by telling us how many abnormal nodes they see. But then importantly, we are putting a clip in the index node. So usually it's the largest node. And then we're doing the targeted axillary dissection. And so, most of the time, if you use the blue dye and the isotope, about 70% of the time, the clipped node will be a sentinel node. But unfortunately, sometimes it's not. And so it's about 25 to 30% of the time. So that's why we're also localizing that clipped node to make sure that we remove, all of the sentinel nodes and the clipped node. So that's typically going to be 2 or 3, maybe 4 lymph nodes. And so we're evaluating those pathologically. If those nodes are all negative, the patient's going to be very unlikely to have 4 positive lymph nodes. So we're selectively looking at that pathology to see if the patient needs a completion lymph node dissection.
Perfect. And just to complete the question, for example, if you have a luminal A patient, you do a ultrasound and you have just 1 positive node. What do you do? Do you biopsy it, or you forget about it and go for a targeted axillary lymph node dissection, or just the lymph node, the sentinel lymph node, to remove this node? Or do you do neoadjuvant chemotherapy?
Yeah, it depends on the patient. So if it's luminal A and it's a low Ki-67, it depends on whether it's a premenopausal or postmenopausal patient. And so we might use the oncotype recurrence score assay on the primary tumor before deciding, exactly whether they would need systemic chemotherapy or not. So we're not using just the nodal status alone any longer, I think. And that's why I liked showing the West German study group and other studies, because I think using some systemic therapy may be appropriate, like a run-in with endocrine therapy, but not, we know that not all hormone receptor positive patients with positive lymph nodes will benefit from chemotherapy. So we're trying to selectively identify those who would benefit. And if we think they do, they have a high recurrence score and so on, then of course we would consider using the chemotherapy in the neoadjuvant setting to help downstage the tumor and any regional nodes as well.
Perfect. Thank you very much.
Thank you.
Muchísimas gracias, doctora Hunt. La verdad, muy interesante la charla. Gracias, doctor Brenelli. Vamos a continuar con el programa. Ahora tenemos a la doctora Silvia Formenti, que es la jefa del Departamento de Oncología del Well Cornell Medicine, de Radiación Oncológica del Well Cornell Medicine, y va a hablar del tratamiento del cáncer de mama con radioterapia e inmunoterapia. El moderador va a ser el doctor Carlos Castro. Doctora Formenti, ¿puede compartir?
I'm going to talk about a subject that is still quite experimental. These are my disclosures. So I'm going to divide my talk in 4 parts: cancer as an individual, selective immune alteration of the host, the immunogenic effects of focal radiotherapy, a little bit of evidence from the preclinical to the clinical translation. And I'm going to really bring about the lessons from other cancers, because we believe they may apply to breast cancer as well. And I'll show some preliminary evidence in that direction too. And then the challenges we encounter when we translate what we have learned in other cancers to breast cancer. So our immune system protects us from cancer by recognizing transformed cells through the mechanism of immunosurveillance and elimination of the transformed cells. And it does so by recruiting both the innate and the adaptive immune system, and conveys a protection by rejecting these cells with mutations. with the aging and exposure to many oncogenic pressures, whether it is the environment, to pollution, where it's just a simple mechanism of aging and defects in repairing some of these damaged cells, and an aging of the immune system, we start seeing more phenomena called equilibrium. Maybe DCIS could be an example of equilibrium, where there are cancer cells and they're kept at bay. They haven't acquired the capacity to invade and to become real cancers or low-grade prostate cancers. But the cancers we see in the clinic as clinicians have escaped the immune system. And in that case, not only the cancer has been immune edited and selected by the immune system to become unrecognizable and perceived as self, but the cancer has recruited some of the immune suppressive tools we have on board on our immune system that exist to maintain the condition of self. A very fascinating mechanism. So we are learning a lot from basic immunology about this process and the results of escape, and how this escape is systemic, how it has an effect to render the host more immune tolerant toward the cancer. But we're only gradually learning how to combine the standard cytocidal treatments, whether it is chemotherapy or radiotherapy, to interact with this new knowledge of the immune component of cancer. So approximately 20 years ago, we introduced a concept that counterintuitively, radiotherapy, focal radiotherapy, could convert the tumor into an in situ vaccine, an ambitious idea. So when we kill cancer cells with radiation, the type of cell death and radiation induces sends both immune stimulatory signal and immune suppressive signal. Immune suppressive signals mostly coming from the fact that radiation also kills the normal tissue and is perceived as a wound, so the body is trying to resolve it as a wound. But immune stimulatory signals could also prevail over the others, and in fact help mounting a tumor-specific immune response. And that is mediated by the recognition of new epitopes the radiation can induce, and I'm going to discuss later, and the cross-presentation in the lymph nodes of these new epitopes, developing clones of cells that then go back to the tumor and contribute to the in-field response to radiation, as well as convey to the patient this capacity through the immune memory of acquire the knowledge of the tumor. And if the metastases are similar to the tumor, so if the immune system is unblinded to the tumor, then it could also fight metastatic sites, the so-called abscopal effect of radiation, so a local treatment that has systemic effects. Of course, you see very rarely the abscopal effect of radiation, mainly because for the time, as I shown before, for the time tumors are established, they've recruited an entire, multiple, actually, a set of networks that maintain immune suppression. Otherwise, they wouldn't be able to grow, expand, and metastasize. And these go through, as I said before, the immunoediting process, the recruitment of immune suppressive cells, the release of tumor-derived products. So these tumor cells are selected to be capable to express these tumor-derived products that inhibit immunity. And of course, immune evasion at tumor cell level that has been so successfully targeted by new drugs in multiple solid tumors that remove these immune checkpoints. So when you want to test the combination of radiation in this new paradigm, what you do in mice is to grow two nodules and then irradiate one. And of course, the other one generally doesn't go away. But if you add some different types of immunotherapy, you can start seeing a signal also in the other nodules that you wouldn't see with immunotherapy alone. So you start exploiting the combination of the two. So I'm going to show you briefly how we got to conclude that this really exists in the clinic as well. And how did it start? It started with a generous gift of Jim Allison that gave us approximately 20 years ago his monoclonal antibody against CTLA-4 for mice. And we use a model where you grow a tumor on the side of the mouse, and for the time the tumor is palpable, it has already developed metastasis in the lung, very similar to an aggressive triple-negative breast cancer. It's also very similar because it is a cold tumor. As you can see, there is not much of an immune infiltrate in the primary tumor, and rapidly takes the mouse to death through the growth of the metastasis. And we immediately noticed that when we combine a little bit of radiation with the anti-CTLA-4, you get the slowing of the growth of the tumor, you get much fewer number of lung metastases, and that reflects on a better survival of the mice. So this synergy could be demonstrated. Also, we're able to show that if you now take out from the draining nodes close to the tumor implanted on the side of the mouse, the lymphocytes, and challenge them with an antigen that is part of the cell line that induces a tumor, only the lymphocytes of the mice treated by the combination are capable to build an immune response compared to the other group. So we are, in fact, immunizing them against their tumor. And then the evidence came from a patient that had read the story in the waiting room of the cancer center when I still was at NYU. And he had, at that point, he had metastatic non-small cell lung cancer that progressed after 3 lines of chemotherapy, chest radiation. He had really no other options, and was sent to me actually to palliate a bone metastasis. But he read in the waiting room the story about mice, and he didn't take no for an answer, and insisted in be treated the way we treated our mice. And we had to write a very special informed consent. And at the same time, we're preparing a protocol for lung cancer patients to combine anti-CTLA-4 with radiation. So we had just to accelerate a little bit the approval of the protocol. But in any event, we off protocol treated him with focal radiotherapy just to 1 lesion in the liver. As you can see, he had innumerable lesions in the liver, and pulsed it with ipilimumab, 3 milligrams per kilogram, for 3 weeks after the first radiation for 4 cycles. I'm actually surprised the patient had a remarkable response. And then gave 2 more cycles of ipilimumab. And in fact, the patient got into complete remission. And this was almost 9 years ago. And here is a patient just before Christmas of last year when he came to visit me, and has received no other treatment, no other PD-1 and so on. So somehow, when it works beautifully. And of course, I'm extremely happy every time I see this patient. So this patient gave us the courage to mount a clinical trial with a gift from Bristol Myers Squibb of the drug. So it was a drug-only support. And we were treating patients like the patients I showed you with radiation therapy to 1 metastasis, where chemorefractory metastatic non-small cell lung cancer. 41% of these patients had metastasis to the brain, so we're very advanced. And equal performance status more than 1 in the majority of these patients, or equal than 1, and multiple cycles before. And only half of them were strong enough to complete the 4 cycles of ipilimumab because of their advanced status. But nevertheless, we started seeing signals with unexpected clinical CR as well as PR and stable disease that compared to the performance of ipilimumab alone in this disease was quite remarkable. So somehow that 1 treatment of 3 doses or 5 doses, depending which fractionation we use, of palliative radiotherapy to 1 lesion, reposition ipilimumab in this disease, in this advanced disease. But also this study gave us the opportunity to understand more the mechanism. And what we know from preclinical work from our group and many others, that are listed down here, is that the mechanism behind the recruitment of the innate immune system by radiotherapy depend on the fact that we break DNA, the DNA becomes available into the cytoplasm, moved from the nucleus or the mitochondria to the cytoplasm. And once it's in the cytoplasm, very similar to the way we respond to the viral DNA, it elicits, it jumpstarts an immune response by being sensed by the machinery of cGAS STING that induce the genes for interferon. And then type 1 interferon is crucial for recruiting dendritic cells at the site of the irradiated tumor. This type of BAF3 dendritic cells that are really mediated by type 1 interferon are the best cross-presenting cells that are capable to present the neoepitopes to the lymphocytes in the lymph nodes and then build a direct immune response. And in fact, in the patients I showed you in this lung cancer trial, there was an increase in circulating type 1 interferon in the blood in the patients who responded compared to the ones who did not respond. At the same time, radiation has a capacity to elicit a lot of survival and repair pathways in the cancer cells. And if there are mutations in those pathways, they are much more likely to be now transcribed and translated and presented eventually to the immune system, as shown by the schema. And in that cohort of patients, we had a responders, patient with brain metastasis who went into CR, that in fact display an immunogenic mutation. And we detected it by following the clones of T cells in his blood before and after radiation. And here you can see that these two clones, one was pre-existing and got expanded, the other one was not there and came after radiation. But the T cells of the patient started recognizing a neoepitope that probably participated in their complete remission of these patients, and only the clone, this patient has response only toward the mutated protein, but not toward the wild type. So an individual mutation of the patient that contributes to the immune response. So the recruitment of the adaptive immune system in addition to the innate immune system. So we went back to the lab, and this is work done in collaboration with Sandra De Maria, and she irradiated the 41, this again, the breast cancer cells I showed you before, and was able to detect in the irradiated cells some radiation-specific mutations, and they with genes that were transcribed and translated, and honed down on by looking at the MHC, so the machinery of cross-presentation of the mice, the best match for the MHC class 1, gone down to 5 candidates to make a vaccine against this tumor that was induced by irradiating the tumor cells. And then also she confirmed by elution of from the blood of the mice that these epitopes existed, and in fact elicited an immune response. And then she treated the mice with this vaccination and was able to then inoculate the tumor after the vaccination, and then continue to vaccinate the mice, no immune checkpoint blockade, only radiation, and was able to show that, in fact, if you give the vaccine, you delay the growth of the tumor weight is less, and you have fewer metastases in the lung and more immune infiltration with less regulatory T cells. So an effect of radiation-induced specific tumor vaccination in mice. And many, in the reality, in the clinic, many other variables influence the recruitment of the innate immune system, whether you treat with radiation or any other cytocidal treatment, including P53, which is this tumor suppressor genes we're all very familiar with. And it turns out that intact P53 tumors, we all know they do much better than mutated P53 tumors across the board. But now we have an explanation from an immunological point of view, because P53 is capable to participate in innate immune response by inducing E2 ubiquinine ligase TRIM24 that connects to a brake, removes TREX1, and I'm going to show you in a minute why that is relevant. By removing TREX1, that will chew up the fragments of cytosolic DNA that I showed you are so important to jumpstart the immune system by inducing interferon. So by removing a block, P53 releases that effect of the cytosolic DNA and induces an anti-tumor response. Conversely, if you have a mutant P53, you lack this mechanism, so TREX1 prevails, removes the substrate, and in addition, it also, mutant P53 binds to a kinase, a protein kinase called tank binding protein kinase, here it is, that also blocks the induction of interferon. So now we can see a role of P53 in conditioning the innate immune system as well. And loss of the genes that control P53 is common in breast cancer across all the subtypes of breast cancer. The darker color is a loss, so 44% over 2, 41% in triple negative, and 31% in ERPR positive tumors. There is a total loss of this tumor suppressor gene. And it does modify the immune infiltrate to lose the p53 gene and the effect of p53 and immune infiltration, the cytotoxicity of the T cells, and it can split very nicely. It's 1,100 patients from the TCGA, triple negative, specifically in, this is 1,100, but this is in specific of the triple negative breast cancer patients. You can see a difference in outcome in survival by having mutated versus intact p53. So what have we learned from other cancers where the introduction of immunotherapy has been more prominent? Well, first of all, again, from the preclinical work of a group in Australia, Michelle Tang and Mark Smith, we saw very elegant data in mice with two different models of breast cancer, 41, which is the one I introduced before, and EO771, which is another type of breast cancer. In both cases, they're immune competent mice, but they're different genetic backgrounds. So just to prove that is a much more generalized mechanism that just connected with one model. They tested whether in different group of mice giving immunotherapy, here is anti-PD-1 and anti-CD137, before surgery versus giving after surgery makes a difference. And it's really interesting that consistently across both models, the best was to give it before surgery. So to keep the tumor on site as a source of vaccination. This is without radiation, just for immunotherapy to work is much more strategic to have the tumor on site. It's more complicated to use immunotherapy in an adjuvant setting. And just coming back from ESMO 23, very striking evidence. I'm just showing a little bit of a sprinkle of evidence in non-small cell lung cancer, but there were multiple breakthrough presentations in non-small cell lung cancer, how giving pembrolizumab, so anti-PD-1, preoperatively and in the adjuvant setting of resectable non-small cell lung cancer made a huge difference. And compared to placebo, and here is the data pretty striking, both in terms of pathologic response, but also in terms of outcome, event-free survival as well as overall survival, really curveless split with a hazard ratio of 0.73. So really a practice-changing approach in lung. But food for thought, because when you then analyze in explorative fashion, the subset they also did not achieve a pathologic response, you still have an advantage by recruiting the immune system, suggesting that just helping the immune system of the host as reflects on an outcome in event-free survival that could be advantageous. And this is also true in breast cancer and makes us think and re-ask whether pathologic response is the best surrogate endpoint when we use immunotherapy in solid tumors. This is Keynote 522, as you know, in triple negative breast cancer patients, the addition of neoadjuvant chemotherapy with pembro, followed by adjuvant chemotherapy compared to placebo, resulted in increase in pathologic response and had an effect also in terms of the pattern of disease-free survival that is significant. And when you look at regroup the patient, analyze the patient based on the RCB score, I remind you, this is a nice residual cancer burden score that was introduced by MD Anderson, by Fraser, Simmons, and co-workers, that divides in a prognostically significant way the residual disease after neoadjuvant therapy. But now you reanalyze the trial based on each of the subsets at the time of pathologic response and compare the patients who received the pembro neoadjuvant versus placebo. What I think is really interesting in terms of distant recurrence, and the data for survival is not mature yet, is that you see a little bit of a difference, but small difference in RCB0. The patients were probably the chemo works already very well. Same for RCB1, but you start seeing significant differences of adding immunotherapy, in this case pembro, in the patients who did not achieve a pathologic response or not adequately achieve a pathologic response after chemotherapy. And here is the effect on event-free survival in the ones that, in fact, did not, RCB2, have residual disease after neoadjuvant chemotherapy in the setting of triple-negative breast cancer. So even in the patients where we are not achieving a significant pathologic response, introducing immunotherapy can help the host deal with the tumor and delay progression. Okay, so this is a difficult question for me, because with all the success of chemotherapy in the perioperative setting across malignancies, is there still a room for radiation immunotherapy without chemotherapy? And we had this nice but small prospective randomized trial. I was very fortunate to work with a surgeon who allowed us to test the use of adding non-ablative, very modest dose of radiation in resectable, highly curable non-small cell lung cancer, and compare it together with durvalumab, and compare it to durvalumab alone. So allowed for this window of opportunity trial, and then assessing the surgery pathologic response. And of course, safety was a top priority, because as I said, these are highly curable patients with surgery up front. And we were happy to show that it was comparable toxicity between the two arms. And we were just 2 cycles of durvalumab, so minimal immunotherapy, minimal radiotherapy, incredibly high tolerance to this regimen, so a good approach for elderly patients or patients who are too frail to be treated with neoadjuvant chemotherapy. And we were able to show that there was a big difference in major pathologic response. And if you remove the EGFR positive mutation carriers, even more of a gap. And really an observation that was pretty provocative, because maybe there is a subset where we could avoid chemotherapy, and that triggered Pacific 4, where patients are stratified whether EGFR positive or not. If they're EGFR positive, they're treated differently with osimertinib, but otherwise, and they're treated with SBRT before Tagrisso. But if they are EGFR negative, they are randomized to SBRT plus Durva, little higher doses than what we did in our pilot trial versus placebo, and they're going to be assessed for progression-free survival and overall survival. And this, I think, will be an important trial, because may be an option for more frail patients. So how do we now transfer all of this to breast cancer? So breast cancer is a big challenge. They are cold tumors in the majority of the case. This is a nice analysis of the ECOG trials that Sylvia Adams did years ago. And as you can see, they have 0 to 10 TILs in 69%. And the more infiltrate you recognize at baseline, the better the outcome in terms of overall survival. So it is a predictive and prognostic factor. So we took on breast cancer, and I tried desperately to reproduce what I had demonstrated in non-small cell lung cancer, in breast cancer, and we chose to interfere with TGF-beta. That seemed to be a good target for breast cancer. I don't have time to show you the preclinical background, but we had really promising preclinical data. And we collected, in collaboration with UCLA, a small series of patients that were treated with a combination of a monoclonal antibody against TGF-beta and focal radiotherapy. And here I'm showing one that, by the way, had resolution of these keratoacantomas as well while we're giving anti-TGF-beta, and some resolution of her tumor, so a partial response. But in a series of 24 patients, nobody had a CR, and most importantly, we saw just one case of abscopal responses outside the field. But when we analyzed it, the trial randomized the patient to 2 different doses of this fresolimumab, the antibody against TGF-beta. And we noticed that the patients that got higher dose had a better outcome compared to the ones with lower dose, and started in red, the 10 milligrams, showing a shift in this kind of plot for measuring the changes in immune monitoring towards central memory and an increment of naive effector cells compared to the patients with lower dose. So we had some signals, we were immunizing them, but not enough to make a difference in their outcome. And I just want to remind everybody that, as I showed you before, the elimination, the equilibrium, all these stages, but we have to keep in mind that across tumors, there are different mechanisms of immune evasions. And while in melanoma, interference with PD-1 and PD-L1 and anti-CTLA-4 and CTLA-4 have demonstrated to reflect on survival, in breast cancer, we are only starting to see this effect on survival, and the survival data is slowly maturing for both ER positive and triple negative patients. We have time to progression data, favorable time to progression data, but most probably in breast cancer, we have the wrong tools. So the existing immunotherapy may not be ideal for breast cancer, because in breast cancer, there may be different mechanisms of immune evasion. And in this direction is a nice preclinical working and done in the Sandra De Maria's lab, where she did the single-cell RNA-seq and preclinically tested a bunch of different immune checkpoint blockades in combination with radiotherapy, and was able to show that the only setting where she really saw a difference in both the irradiated and the abscopal tumor was to add to anti-CTLA-4 the CD40, which is increasing cross-presentation and somehow an enhancer of cross-presentation, but not adding anti-PD-1. So it's possible that we're still exploring what is the perfect cocktail to induce an immune response in patients with breast cancer. We're doing so at Cornell by analyzing in different subsets. Dignity, which is a non-interventional study looking at organoids and testing a lot of preclinical experiments in organoids of triple negative breast cancer, and now we're expanding to ER positive and HER2 positive breast cancer. We're doing it in combination with CDK4 and 6 inhibitors in ER positive HER2 negative breast cancer, and in combination with pembro and selective treatment of 1 or 2 brain metastases in patients with multiple brain metastases of any type of breast cancer, and with different randomized to different form of neoadjuvant immunotherapy with radiation in locally advanced EBR, estrogen positive breast cancer in this trial in CBCB. So in conclusion, tumor host characteristics result in individual signatures of immune evasion requiring a precision therapy approach to overcome them. Evidence for the important role of immunotherapy is gradually emerging in breast and other cancers. Radiotherapy has immune effects that can synergize with current immunotherapy, particularly in patients who cannot tolerate chemotherapy. And I'll stop here and recognize our group of different PIs in the lab, and most importantly, our patients that make this work possible.
I just have a couple of remarks.
Yes.
It's very exciting, your lecture, and exciting messages about the innovation in breast cancer treatment. My question would be, is there any or many clinical trials going on regarding immunotherapy in breast cancer treatment? Because certainly it's an innovation in many cancer types, very costly, very expensive. And I would like to know if there's enough clinical trials going on not to get worried about the cost of immunotherapy in breast cancer.
Yeah, I think the issue of financial toxicity is extremely relevant. I just gave a talk at Astro about how it is really the responsibility of United States and Europe to conduct these studies and establish evidence before we try to take it to the rest of the world, because the costs are exorbitant. And even in established settings where it is FDA approved and is even from the European point of view approved modality, immunotherapy costs a lot in the United States. We calculated for a Medicare patient is still $2,000 a month to undergo anti-PD-1 or anti-PD-L1 therapy for lung cancer. So they have to pay out of their pocket what often is the retirement check. So is really not realistic. You're making an extremely good point. I think the reason we embrace it from a research point of view is because it really shifts the attention from biologically from treating the tumor to treating both the tumor and the immune system of the patient. Both are the cause of the disease.
Thank you very much. No further questions.
Thank you.
Excelente presentación. La siguiente conferencista es la doctora Judy Buggy. Ella es jefa de la Dirección de Cirugía y de Melanoma de la Mayo Clinic de Rochester. Va a hablar sobre manejo de pacientes con cáncer de mama ipsilateral múltiple y el moderador va a ser el doctor Fabrizio Brenelli. Dejo de compartir para dar paso a la doctora Judy Buggy.
Good morning, good afternoon. It's a pleasure to be here today as part of this amazing course. I'm going to start sharing my slides. Does that look good? Excellent. So it's a pleasure to talk today about breast-conserving surgery for women with multiple ipsilateral breast cancer. You can see here my disclosures, none of which are relevant to the information that I'll be discussing today. So we're going to talk about the historical data in terms of the management of multiple ipsilateral breast cancer. We're going to talk about the prospective trial Z1102, and then we're going to look at some of the data from that in terms of conversion to mastectomy, the cosmetic outcomes, and the oncological outcomes at 5 years. So in terms of the background, we have seen an increase in the diagnosis of multiple ipsilateral breast cancer as we continue to see patients in clinical practice. And this is predominantly due to improved imaging and increasing use of breast MRI. These days, we can find multiple ipsilateral breast cancer is detected in about 13 to 27% of patients that undergo a preoperative MRI for their workup of their breast cancer. When we look back at our historical studies from the 1960s and the 1970s, these studies, which were performed as retrospective studies, showed relatively high rates of local regional recurrence when these patients were treated with breast-conserving therapy. And this has led to the standard of care being a use of mastectomy for these women. However, more recent studies have shown much more acceptable local recurrence rates. And this is because, as we all know, our management of breast cancer has changed a lot over the last several decades. And we've seen significant improvements in our modalities for breast imaging, in our pathological margin assessment for negative margins, major advances in systemic therapy, as well as in radiation therapy. And so these retrospective studies from the late 1900s showed some lower local recurrence rates. So with that in mind, we designed the ACOSOG Z11102 clinical trial as a single-arm phase 2 trial to assess whether the local recurrence rate at 5 years for women with multiple ipsilateral breast cancer treated with breast-conserving surgery and whole breast radiation was greater than 8%. So that was our predefined primary objective. Secondary objectives were to look at conversion rates to mastectomy, patient perception of cosmesis, adverse effects from the breast-conserving surgery and radiation, and side effects from the radiation. The study enrolled patients from July 2012 to August of 2016, and this enrolled patients that had multiple ipsilateral breast cancer, which was defined as 2 or 3 foci with biopsy-proven malignancy within one breast, and patients that were interested in breast-conserving surgery were enrolled in the study. Patients underwent breast conservation with lumpectomy along with ipsilateral axillary nodal staging at the discretion of the treating surgeon. And then they received adjuvant chemotherapy at the discretion of the treating medical oncologist. And importantly, neoadjuvant therapy was not permitted on this trial. Radiation therapy was protocol directed and required whole breast radiation with a lumpectomy, with a boost to each of the lumpectomy sites. And then regional nodal radiation was at the discretion of the treating radiation oncologist. And as one would expect, adjuvant endocrine therapy was recommended for patients with ER and or PR positive breast cancer. And then patients were followed every 6 months through 5 years of follow-up from the time of completion of radiation. Patients eligible for this study had to be over the age of 40. As I mentioned, it was 2 or 3 foci of biopsy-proven malignancy. At least one of these foci had to be invasive disease. And there was a requirement of at least 2 centimeters of normal appearing tissue between each lesions on imaging. No more than 2 quadrants of the breast could be involved with the breast cancers, and patients had to be either clinically node negative or have clinical N1 disease. At the initiation of the trial, we did require all patients to have an MRI within the 45 days prior to registration, and subsequently the trial was amended to make that MRI optional. Patients who had more than 5 centimeters of disease were excluded, as were those with bilateral breast cancer, previous ipsilateral breast cancer, or unknown deleterious mutation, although not all patients had genetic testing. As I mentioned earlier, neoadjuvant therapy was not permitted. So as we look at the patients that were registered prior to surgery, there were 198 patients registered prior to undergoing surgery. Median patient age was 62, and the vast majority, 96% of patients, had 2 areas of biopsy-proven disease, with just 8 patients with 3 foci of disease. And about a quarter of the patients had 1 site of DCIS. When we look at the final pathological site results, only 4% of patients were found to actually have 1 single contiguous lesion. The vast majority were truly multiple ipsilateral breast cancer. And of those 8 patients that were found to have 1 continuous lesion, 6 were able to successfully treat breast conservation, so 75%. And a quarter of those, 2 patients, did end up converting to mastectomy. When we look at the surgical approach, and this is a frequent question we get, about 30% of patients had this approached as a single lumpectomy. 70% of patients had this approached as 2 separate lumpectomies. The conversion rate to mastectomy was very low at just 7%. So 14 patients converted from breast conservation to mastectomy, leaving 93% of patients successfully completing breast conserving surgery. How did they complete this breast conserving surgery? The vast majority were able to achieve this with a single operation to negative margin, 74%, with 23% of patients requiring a second operation to obtain negative margins, and just 5 patients, or just under 3%, requiring 3 operations to successfully complete breast conserving surgery. During the course of this study, the margin guidelines were adjusted with the publication of the ASTRO guidelines recommending no tumor on ink as being adequate for patients with invasive breast cancer. It's interesting to note that those patients that were registered prior to those margin guidelines, about 64% were able to complete their surgery within 1 single operation. Once we adopted the new margin guidelines, 75% of patients were able to complete margin negative resection in a single operation. So overall, this was the initial findings from the study, showed that breast conservation was a feasible alternative to mastectomy. The conversion rate to mastectomy was acceptable at 7%. The re-excision rate requiring a second operation was around 30%, was acceptable. And we did not find any statistically significant factors that were able to predict which patients were going to need to convert to mastectomy or need to have a reoperation for margin re-excision. So moving on to the cosmetic outcome of these patients, we assessed this in 2 ways. We had the patients complete the BreastQ breast conserving therapy module, which has been validated for patient-reported cosmetic outcomes. And this was administered to patients at 1 month, and then 6 months, 12 months, 18 months, 24, 36, and 48 months, and ultimately at 5 years after surgery. And then we also used the very simple breast survey, which is essentially a 4-point scale where 1 is excellent cosmetic outcome and 4 is poor cosmetic outcome. And we assessed this both from the surgeon's standpoint at 1 month and then also from the patient's standpoint at all of the same time points as the BreastQ module. What you can see here is the results from 216 patients followed up over a median of 49 months. As one would expect, the survey completion rate declined to about a half at 3 years. And we can see that the vast majority of patients reported that they had a good or excellent cosmetic outcome, both at 2 years and at 3 years, 70% of patients viewing their cosmetic outcome as good or excellent. When we look at the BreastQ scores, we can see that the patient's satisfaction with breast remained high throughout their postoperative course. The effects of radiation were most noticed at about 6 months after radiation, but then improved over time. And the patient's physical well-being improved over the time of their 5-year follow-up. When we compare this data to published results from unifocal breast cancer, we can see that a good or excellent cosmetic outcome noted by about 70% of patients in this study is very similar to what we see as the cosmetic outcome with breast-conserving therapy in patients with unifocal breast cancer. And furthermore, when we look at the BreastQ scores, looking at both breast satisfaction and well-being, we can see that the results from the Z112 study are very similar to the results that have been seen in other prospective studies of breast conservation therapy with unifocal breast cancer. So overall, we have shown that the patient-reported outcomes with breast-conserving therapy for multiple ipsilateral breast cancer is acceptable. Patients report high rates of satisfaction with breast and physical well-being, and that the cosmetic outcomes were not associated with any factors that we could identify. We looked at patient age, tumor size, disease stage, the number of incisions, the approach for the lumpectomy, and the radiation dose. So then we come on to the primary endpoint of the Z1102 study. And as I mentioned, this was defined as an acceptable 5-year local regional recurrence rate for breast conservation being less than 8%. Of the 270 patients that enrolled in the study, we had 204 patients that were evaluable for this primary endpoint. When we look at those 204 patients, the median age was 61. Vast majority, 59%, had clinical T1 disease, with 41% of patients having clinical T2 disease. Majority of patients had ER positive, HER2 negative breast cancer, and we'll discuss this again later. That accounted for 84% of our patients, and 78% of patients were pathologically node negative, with about 23% having positive nodes at surgery. And our median follow-up is 66 months. 6 out of the 204 patients have developed a local recurrence. 4 of these on the ipsilateral breast, 1 in the ipsilateral skin, and 1 in the ipsilateral chest wall. This gives an estimated local incidence of local recurrence at 5 years of 3.1%. Important to note that 95% confidence intervals scan from 1.3 to 6.4% and remain well below that 8% predefined clinically significant threshold. When we look at the other outcomes of the patients, in addition to the 6 patients that had a local recurrence, there were no patients that developed a regional recurrence in the ipsilateral lymph nodes. There were 6 patients that developed a contralateral breast cancer, and there were 4 patients that developed distant disease, 1 in the bone and bone marrow, 2 in the bone, and 1 in the lung. There were 3 patients that developed new non-breast cancer primaries, and of the 8 patients that died during the follow-up period, 7 of these were not breast cancer related. We then try to look at factors that may influence local regional recurrence, and this is very challenging to do given the fact we only have 6 patients that actually experienced a local recurrence. When we look at the number of foci of disease within the breast, as we mentioned, the vast majority of patients had 2 areas of biopsy-proven disease, but there were no recurrences in the patients with 3 foci of disease ipsilaterally, although obviously this is limited by small numbers. When we look at the pathological T category and the pathological N category, there was no statistical significant difference between smaller tumors and larger tumors, or node negative and node positive, although we do see a numerically difference in that the local recurrence does tend to be a little bit higher with larger tumors or node positive disease, but did not reach statistical significance. Similarly, when we look at margins, numerically, the local recurrence rate is lower with negative margins than with close margins, but this did not reach statistical significance. And we saw no difference between ductal and invasive lobular histology. As I mentioned earlier, the vast majority of patients had ER-positive, HER2-negative disease, 83.5% of the patients. And when we look at our local recurrence by tumor biology, in this group, the local recurrence rate was 2.6% 5-year estimated local recurrence rate. In the 23 patients with HER2-positive disease, there have not been any local recurrences. And in the small group of just 10 patients with triple-negative breast cancer, there's been 1 local recurrence for a 10% local recurrence rate, obviously limited by the small sample size here. Breast MRI was initially required on all patients prior to surgery. And in 2015, we amended the protocol to allow enrollment of patients who had not had a preoperative breast MRI. Interestingly, the vast majority of patients on the study, 93%, did have a preoperative MRI. But there were 15 patients, or 7%, that did not have a preoperative MRI. And 3 local recurrences occurred in those with an MRI, and 3 occurred in the 15 patients without an MRI. This was an unplanned secondary analysis, and it obviously is not powered to look at this question, but we do know a significantly higher 5-year estimated local recurrence rate in the patients that did not have a preoperative MRI than the 1.7% seen in those patients with a preoperative MRI. Another factor looking at risks of local recurrence was the use of endocrine therapy. This analysis obviously was limited to those patients that had at least 1 lesion that was ER positive. And as we see in unifocal disease, we see that the estimated 5-year local recurrence risk was much lower at 1.9% in the patients that did have adjuvant endocrine therapy than the 12.5% seen in those patients that did not have adjuvant endocrine therapy. So there are many limitations to this study. It is a single-arm study. The small subsets that I discussed, especially those that did not have a preoperative MRI, or those patients with HER2-positive disease or triple-negative disease, and those patients that had 3 foci of disease, were all relatively small, limiting analysis. And one could argue that the 5-year follow-up time on this clinical trial was short, given that the majority of our patients had ER-positive disease. That said, it's the only real prospective data that we have looking at multiple ipsilateral breast cancer management. And we have shown that for those patients that have multiple ipsilateral breast cancer that pursue breast-conserving surgery, along with adjuvant whole breast radiation and lumpectomy site boost to each lumpectomy site, we showed a low rate of local recurrence of 3.1% at 5 years. It's important to note that the majority of the patients enrolled in this study were postmenopausal, had ER-positive HER2-negative disease, had 2 foci of biopsy-proven breast cancer, and the majority were node-negative. The factors that we identified that seemed to impact local recurrence was the use of a preoperative MRI and the use of adjuvant endocrine therapy for those patients with ER-positive breast cancer. Overall, we conclude that breast-conserving therapy is a reasonable consideration for women diagnosed with multiple ipsilateral breast cancer. Thank you for your attention. I'll be delighted to take any questions.
Hi, hi, Dr. Judy. It's Fabrizio. Nice to see you again.
Hi. Wonderful to be here.
Yeah, we are missing you here in Brazil. Dr. Judy, just one question. Do you think it's feasible in practice to perform multiple resections without pre-op MRI? I know the data that you showed, you have just a few patients with pre-op MRI, but it looks like it's a good point to decide who to perform breast conservative surgery or not. What do you think about that?
Yeah, I mean, I think the MRI data, like I say, it's underpowered. It was an unplanned secondary analysis, so I really don't want to hang too much focus on that. The way that I'm interpreting that for my practice is if I do have a patient and they go through mammogram, ultrasound, biopsy, they come to see me and they have 2 or 3 areas of disease within the breast, and that patient is motivated and would like to have breast conserving surgery, then I do think having an MRI before surgery is helpful in terms of planning my approach and planning the extended resection and just making sure that there isn't a 4th or a 5th focus of disease hiding in the breast. So I definitely am not saying that all women with unifocal breast cancer need an MRI. I think we are waiting for the results of other trials that will address that question. But I think if I have a patient that already has 2 or 3 foci and they want breast conservation and I have access to an MRI scanner, I think it's reasonable to proceed with an MRI. I think if the patient can't have an MRI for any reason and really wants to proceed with breast conservation, it's probably still reasonable to proceed that way.
Well, perfect. I don't know if we have any time for other question.
Sí, Fabrizio, para una pregunta más.
Okay. Do you have any data on your study about the boost? How many patients had boost, like a double boost in the breast? And do you think this could decrease the aesthetic result for the patient?
Yeah, so the protocol, all the patients treated on this protocol did have to have whole breast radiation. And then the protocol did require a boost to each of the lumpectomy sites. So all of these patients would have had a boost to each site of the index malignancies. And looking at the cosmetic outcomes treated that way, they were very successful. So it seems like boosting both sites did not negatively impact the cosmetic outcomes. And then there was also another paper that we published that showed that the radiation oncologists really did a very good job. They had no problems kind of adhering to that RTOG-directed protocol of whole breast radiation with a boost to each lumpectomy site. But that's also a lot why the requirements for the study said no, you couldn't have disease impacting more than 2 quadrants of the breast because it needed to be, feasible to boost both lumpectomy sites.
Perfect. Thank you. Nice to see you again.
Nice to see you. Thank you so much.
Nice weekend. Thank you.
Bueno, vamos a continuar con la charla, con las conferencias. Va a hablar el doctor Roberto Orecchia, director del Instituto Europeo de Oncología de la parte científica. Va a hablar de la influencia de la inteligencia artificial en la radioterapia práctica. Doctor, puede compartir pantalla.
First of all, thank you so much for your invitation. And good morning to everybody, all the participants. My topic will be on the influence of artificial intelligence on the practical radiation therapy. Just a short introduction, starting from the definition. There are many definitions of artificial intelligence. We can consider this a branch of computer science dealing with the simulation of intelligent behavior in computers using algorithms established by humans and learned by computer methods. We have different forms of artificial intelligence. One is machine learning, ML, that train PC when then leave to make decisions. And the more sophisticated type of artificial intelligence is the deep learning that try to use the brain-like model to make a decision and include also neural network with different architecture types. An overview on the use of artificial intelligence in oncology can be used in practice in all the phases of the management of the patient. Means in prevention, medical imaging really important, notably radiology and pathology mainly. For diagnosis, not only for medical imaging, but also assist colonoscopy, colposcopy, and molecular feature. Important role also in research for drug development, repurposing of drugs, clinical trials. Useful in clinical setting for prediction of clinical relevant parameters like stratification of the risk, response to therapy, complication and side effect, and main outcome like survival and disease recurrence. Artificial intelligence is very useful in moving to precision oncology. That means today a multi-omics integration. Just to give you some information about bibliometric assay or what is happening in the literature about paper published on cancer. You can see here tremendous increase in the recent years. Machine learning too, an increase, and the combination of cancer and machine learning also is strongly increased. In 2020 has been published more than 6,000 papers on machine learning in cancer, increased to less than 8,000 in 2021. You have to consider that recently, no more than 5 years ago, usually the average was about 1,000 papers per year. It's a long history because the first paper published on artificial intelligence and cancer is in 1983. That means 40 years ago, a really pioneeristic era. If you look in the keyword, breast cancer is really important, machine learning, deep learning, classification, diagnosis, and for radiotherapy, segmentation, computer-aided diagnosis, gene expression, etc. This is the status of the device that has been approved by FDA for oncology-related field. You can see here that the majority is in the area of diagnostic with radiology, is the most frequent number of tools, about 55%. Also, digital pathology is increasing and reached about 20%, but also radiation therapy is well positioned with about 9% of the total of the tools currently available. In terms of cancer site, breast is the most important, the most frequent cancer type used, and also lung and prostate follow with about 80%. What are the perspectives of artificial intelligence in radiation oncology? As I mentioned before, surely artificial intelligence can help in realize precision personalized radiotherapy. And the goal is to stratify patient and precisely treat each individual patient, means treatment really personalized. Three main areas. One is radiobiology and molecular oncology. That means better patient stratification, individualization of the treatment, novel therapeutic strategies, and prediction of treatment failure. The second is in general radiation therapy health service, like patient-centered radiation therapy, optimal radiation therapy utilization, awareness, aging patient population. In clinical setting, in practice, we have and help in imaging analytical tools, in mathematical modeling of outcome, optimization of treatment delivery, and optimization of treatment protocol. So it means that using state-of-the-art technology and biomarkers is really useful in order to improve treatment outcome and reduce adverse effects and complications. The challenge today is to get to move in the direction of multi-omics integration for a better understanding of the biology of the tumor and also of the patient, integrated different omics, classic omics like genomic, epigenomic, transcriptomics, proteomics, metabolomics, and other, with the growing interest in integration with image-derived analysis like radiomics. You can see here an example of the map that is possible to obtain, for example, for different type of radiological imaging. The fil rouge of integrating omics is very close to realize the concept of biology-driven radiation therapy. What about radiogenomics for radiomic feature, genetic information within individual tumors, imaging genetic biopsies with the analysis of high-dimensional imaging data, radiomics, mutational and gene expression data in order to characterize individual tumors. The goal is to convert digital radiology in genetic assessment of the individual tumor, and the plan is to develop a bioinformatic pipeline for a correlative analysis of radiomics data with gene expression and mutational data. About toxicity, so means the analysis of individual genetic variation that affect the response of normal tissue to radiation, so means prediction of radio toxicity. We know that 80% of the variation in clinical response for toxicity in particular is due to patient-related factors. The goal is to identify germline variants and somatic epigenetic transcription factors, modulating biological response of normal tissue to radiation, and the plan is establish a gene-based predictive test for normal tissue radiosensitivity. The final goal is to obtain this type of predictive model, very fascinating, not in clinical setting today, but this is like open a window for the future. This is a very recent paper in the predictive in pre-treatment and during treatment period. For example, the incidence in lung cancer submitted to radiation therapy, the incidence of grade 2 or more radiation pneumonitis. You can see very complex algorithm, but at the end it's possible to do, at least in experimental phases. Also, is really important to understand during the treatment, in early phase of the treatment, again, the same type of prediction related to, for example, again, radiation pneumonitis grade 2 or more, but also to be able, before ending the treatment, to establish the probability, to estimate the probability to obtain a local control. So we are still in time to change, for example, the therapeutic approach. Moving to practice, as requested in my topic, is what we can do now, less than you have seen before. But anyway, the utility of artificial intelligence can be manifested in most or almost all the phases of the process of radiation therapy, means diagnosis and pre-radiation therapy workup with algorithm used to enhance lesion detection, tissue characterization, and diagnosis. In the phase of simulation and contouring, the auto-segmentation of organ at risk and target, treatment planning and plan evaluation, knowledge-based planning, automation of plan generation, and class solution, model to predict dose distribution, the field of dosiomic, for example, quality assurance in order to predict and classify quality assurance result, treatment delivery, machine learning, in this case, to track tumor, body, and treatment rooms component to reduce setup errors, automated method of optimization of adaptive replanning, of follow-up and toxicity and efficacy. So many improvements, and some tools are already available, not at the same level in all the steps, but it's just a beginning, just more detailed in the different phases of what happened in order to still science, so type of intelligence approach. You can see a strong increase in deep learning and machine learning. And this is a field of application according to the publication, so means innovation. Machine learning is useful mainly in outcome prediction, more sophisticated deep learning for image segmentation, treatment planning, synthetic image generation. So you can see that very wide application of type. One of the examples is also in the organization of the flow or the workflow for radiation therapy department, both for patient and the staff, in order to create optimization in scheduling the workflow. One of the modality, and already exists on the market, the possibility to use this type of software, is the natural language processing, NLP. This is the intersection of linguistic computer science and artificial intelligence, and able to offer solution to convert unstructured text into normalized and structured data suitable for analysis or to drive algorithm. How NLP can help in radiation therapy is maybe useful in the process of clinical decision support, in improving productivity of the staff of the department, increase accuracy, very useful for report of critical findings and recommendation, labeling of key imaging, storage of key imaging, useful also for the follow-up. Interesting, the multilingual transformers, spelling errors, synonymous, abbreviation, reporting in different versions, and integration into multidisciplinary units. The field in which all of these specificities is in the frame of regulatory approval in terms of report and reimbursement, and also to how to integrate these in the hospital information system. The most frequent use today in practice is the auto-contouring. That means the use of in the phase of pre-treatment planning. And now The standard is manual contouring of organ at risks, primary tumor, and nodal region. But we know this is perhaps the most laborious but crucial component of the role of radiation oncologist. Error in this process can lead to underdose tumor and increased toxicity, means less efficacy and more complication. Currently are available a series of atlas-based contouring tools, but usually are limited by availability and accuracy, and also require time for significant manual input. Progresses in artificial intelligence led to the development of different methods in order to take more accurate and efficient auto-contouring. This paper, very recent, is a survey in which auto-contouring was felt to be one of the most popular AI-supported applications, with about 80% of the interview reporting a positive impact on their practice or practice of radiation oncology. And today we can say that artificial intelligence auto-contouring is definitively migrated from the domain of research to commercially available products. Of course, nothing is perfect, and such product might represent the ideal solution, but again, several important considerations, so keep attention for radiation oncology, including the need of quality assurance and validation, and a really important education, training, and job planning for all the professionals. Very interesting is to evaluate the performance of contouring system based on artificial intelligence that are already available on the market. This is an example of what should be the rule. So, for example, in this paper have been compared the performance of 5 most common, most popular commercial auto-segmentation solution: the Mirada, MV Vision, Red Formation, Rise Station, and TerraPanel. Compared with the manually drawn expert contour for, in this case, for 20 breast, 20 head and neck, 20 lung, and 20 prostate cancer patients. Has been used metrics, geometric similarity metrics, like the VDCS, the volumetric and surface dice similarity coefficient, some other technical issue like the outdoor distance and the added path length. And also has been evaluated the time taken to manually draw the expert contour and the time correct for the intelligence artificial contour. You can see that all the 5 commercial tools examined, maybe some difference in the number of CT contour offered by each of them. But the range is quite limited, considering that also with all of these are offering contours of also lymph node levels and organ at risk. The average and median volumetric dice similarity coefficients are good for all the system, and compared with the other report on this same topic, you can see very close range from 0.82 to 0.88. What is also important for the productivity of the department and the time for radiation oncology and medical physics is that all the systems offer a substantial time saving ranging between safe of 14-20 minutes in case of contouring of breast, more in more complex contouring, like in head and neck, 74-93 minutes. Lung is similar to breast, 20-26 minutes, and prostate is an intermediate safe of time, 35 up to 40 minutes. And is similar, is absolutely no different, no statistical difference among the 5 commercial tools examined. Some highlight, this is a paper published in IAO, in my group, in which we look in the literature about the use of the increasing number of tools that are published and presented in research and the literature. You can see a strong increase, especially between 2020 and 2022. Head and neck is the most frequent tumor site used for this tool, followed by brain, prostate, lung, liver, heart, and also breast is not so common, but anyway exists on the market. CT remain the most imaging-based to develop this tool, followed by MRI, PET, and few cases also ultrasound. Tumor and organ at risk are, of course, the most frequent considered tasks. There are, also segmentation challenge, like the comparison, like online system that are also still available, for brain, for kidney, for abdominal tumor, and prostate tumors. And all this possibility show advantages with respect to manual contouring. There are, of course, some limitations. For example, this system often are agnostic with respect to the modality of imaging, like CT, MRI, or PET. We have to consider the role of different pathological and anatomical characteristics of the tumor of the patient, and also there is still a variability in imaging protocol. There are some highlights in order to the lack of benchmark data sets, need for open sourcing code, importance of collecting more high quality data, need to evaluate existing model and training techniques instead of developing new ones. So currently today on the market, there is an overabundance of proposed novel deep learning architecture and models tested, unfortunately, on very few patients. So it means that we have to look to the validation of this model before adopting these in clinical sector. Artificial intelligence tomorrow. Radiomics is absolutely an emerging field of research and also practical application, extraction of different radiomic features, selection, create a map that it describe in a not invasive way the whole complexity of the tissue structure. Why radiomics is so growing in popularity in radiation oncology and also in oncology more in general? Because MRI, PET, CT, and any type of digital imaging are broadly used in current practice, so means large availability of different type of digital imaging. We know also that diagnosis, treatment, and follow-up benefit from already available technologies like mentioned before. Automation by artificial intelligence increase quality of diagnostic staging procedures. Images, really important, are available during all the disease course and also allow to perform retrospective analysis. To overcome the critical limitation of sampling biopsy, radiomics and imaging show all the lesion distribution in the whole body. And imaging data can be also used longitudinally to track modification over the time. Finally, but really important, radiomics is not invasive and can be repeated frequently. Just an example of what means the application of radiomic to create prediction model. For example, the preoperative prediction of axillary lymph node burden with a multiparametric MRI-based radiomics to create some nomogram in early stage breast cancer, high specificity, high positive predictive value, high negative predictive value. This is very useful in order to tailor radiation therapy, especially in intermediate risk group. You consider that the evolution of the information coming from axilla is decreasing. Now, sentinel node biopsy is a standard, and also there is a discussion about to avoid, at least in some low-risk patient, any procedure on the axilla. So there is important to find and to test alternative method, alternative model in order to know more information on the state of axillary lymph node. Another topic for the future already mentioned is radiogenomic. This is the specific application is where imaging feature linked to genomic profiles, but also other biological parameters. And already mentioned imaging genomic that are able to predict genetic information with individual tumors, so means imaging genetic biopsies, and radiation genomics in order to characterize individual genetic variation to predict radiotoxicity. This is a pipeline for radiogenomics, data acquisition and preprocessing of radiomic data and of genomic data, feature extraction and to create phenotype by radiomics feature, and the genotype, association of both the phenotype and genotype, radiomic and genomics, and to create a new map, virtual map, including all the molecular characteristics, data analysis with deep models, machine learning, statistical, heat map, and very useful for many phases of process in oncology, in therapy, like survival prediction, tumor grading, biomarker, clinical decision, precision medicine, risk stratification, and really important treatment selection. Radiogenomic in the next future, could be also very useful for selected patients to be treated with particle therapy. Particle therapy is an emerging field in technology for realize new machine for in the field of radiation. So today it is still discussing the role of particle therapy, mainly due to the cost of this machine. But of course, if we were able to select the proper patient to be submitted to particle therapy instead of X-ray therapy, can be really a progress also in terms of sustainability in national health system. Today, we have few genomic data on response of cell tissue to particles. What we know that we have important physiological difference with respect to densely versus sparsely, means particle and X-rays, partially ionizing radiation. And radiogenomics may be the key for identifying and understanding the molecular mechanism on genes, MRI, protein expression, underlying this differential response. Biomarkers and biosignature that predict low lead radio resistance is important for the use of particle therapy alone as a boost dose in a proper manner. And also really important, hypoxia signature and imaging of hypoxic region of the tumor, timely methodology for treating this target with high lead particle with more geometric accuracy and quantitative approach. The third field for the future is dosiomic. Dosiomic is an extension of radiomics. Dosiomic extract feature from the patient 3D RT dose distribution, so dose volume histogram and other, to obtain specific spatial and statistical information. Dosiomic is able to parameterize dose distribution, in particular region of interest by intensity, textural and shape-based feature, allowing a high complexity level of description that is distinct from those obtained from DWH. And the integration, important, the integration of dosiomic with the DWH could constitute an advanced tool to evaluate RT plan quality, identify new metrics to evaluate our dose distribution. A second important development is the introduction of dosiomic feature into TCP, tumor control probability, and TCP, normal tissue control probability models, overcoming the current limitation of this model. So really important again to select patients. Just an example published recently in literature using dosiomic risk model is able to predict radiation injury, for example, in this case, in a brain treatment, temporal lobe injuries, and of course, to guide individual intensity modulated radiation therapy for this patient. What in the future, just to move to the conclusion, the future is to create a modern and sustainable also radiation therapy. Why not also a sort of a green radiation therapy, avoiding use of energy, for example. We are in a really critical period in the world, and this is what may happen in the next future. What is important also is to share the evolution and of the implementation of artificial intelligence in radiation therapy with the patient. You can see here a survey or patient, and I would like to mention this about the information. A patient said, if a computer gave me the result, I would not feel emotional support. It's important and maintain the need for a strict relationship between the doctor and the patient. Thank you very much for your attention. And when we are moving in high definition radiation oncology. Thank you.
Ciao Roberto, mi ascolti? Come stai?
Vanessa, come stai? Bene.
Piacere di rivederti.
Veramente un piacere.
Okay, hope you're doing really good. I think we have very little time. I'm going to ask only one question for you, and it's one that's very simple that concerns a lot the medical community, is the impact of artificial intelligence on radiation therapy. Are we going to lose our jobs? Should we be scared that artificial intelligence is going to replace physicists, doctors, physics, technicians? We know about augmented intelligence, but please, can you bring some calm to the medical community who's really scared?
No.
Thank you.
No. I hope, and also I believe, no. The role of medical doctors and all the team involved in radiation therapy will remain, at least for many, many years, the same. What artificial intelligence can do is to help, helping us, all of us, in different phases, especially for repetitive tasks. And this is also useful to leave more time to stay with the patient, because it's important. I mentioned it before, the sentence of this patient, so the emotional contact with the doctor. And I believe this type of relation absolutely will be not substituted by artificial intelligence. There are several myths on artificial intelligence, but we have not to forget that artificial intelligence is created on the basis of natural intelligence. So it means it's created by humans. And also it's important that we have to verify in practice what is the quality of the market is offering now and will offer in the next future more, because it's a big business but we have to keep in mind that what is important is to use absolutely validated tools. And this really keep attention, okay?
Okay, doctor, thank you very much for your question.
Gracias, doctor Oriquia, gracias Vanessa, gracias por compartir con nosotros. Hemos llegado al final, vamos a hacer los últimos anuncios para terminar en horario. La verdad, muchísimas gracias a todos. Cari, ¿estás acá?
Sí,
¿Querés compartir? Que no te veo, ahí estás. Vamos a ver un poco para repasar lo que tenemos para el año que viene.
En el 2024 vamos a tener el curso online que va del 20 de abril al 11 de mayo, desenmascarando los signos y dilemas de la práctica diaria, que va a ser gratuito los sábados en la mañana. ¿Querés recordar algunas clases, Darío?
Sí, el sábado 20 de abril, rápidamente si querés pasamos para no tener mucho tiempo. Vamos a hablar el sábado, el 20 de abril, el 27 de abril, el 4 de mayo y el 11 de mayo. Ya igual van a tener más información en los próximos meses. Y también ya está la fecha del próximo teórico práctico, ¿no? ¿Cuándo va a ser, Cari?
Exacto, el viernes 21 y sábado 22 de junio presencial en Argentina, Buenos Aires. Es un curso arancelado, el tercer curso internacional, confirmado la presencia del doctor Vicente Martínez y la doctora Ruby Espejo, que nos acompañarán. El día sábado vamos a tener un taller exclusivo de intervencionismo mamario, donde van a poder participar y trabajar con docentes de todos distintos equipos de Argentina. Y el domingo, Darío, 23 de junio, ¿qué tendremos?
Y el domingo van a tener el taller exclusivo de imagenología mamaria, donde también van a poder participar, ver casos, tratar de trabajar en forma activa en cuanto a imágenes mamarias. Ya a lo largo de este año y probablemente a principios del año que viene van a tener toda la información completa y van a poder tener los links para poder inscribirse. Todavía no están, aunque los cupos van a ser limitados. Contanos un poco.
Invitarlos a sumarse a la página de Facebook y de Instagram, darle like, me gusta, y de esa forma se van a enterar cuando abramos la inscripción, tanto para el curso online gratuito como el curso presencial. Agradecer...
Nos falta eso, perdón.
Sí. Vamos medio rápido, pero queremos agradecer a todo el equipo de Tecnoimagen, a los directivos, a Alex, a Melina por la asistencia técnica. Agradecer a los disertantes, a los moderadores, al doctor Gabriel Farante y a Humberto Veronesi Academy por confiar en nosotros, a ustedes, al público por estar acompañándonos, recordarles que este curso se va a volver a repetir el año próximo, generalmente para estas fechas. Van a tener un certificado todos aquellos médicos que hayan participado tanto en este curso como el del sábado pasado. Va a estar lo que preguntaron todos, si van a estar las conferencias, van a estar la semana próxima subidas las conferencias para que puedan visualizarlas un tiempo más. Al final, cuando cierren el Zoom, van a tener una encuesta por Zoom, pero ahora los queremos invitar también a hacer una votación resumiendo de lo que significó el curso, ¿no? Darío, te doy la palabra.
No, exactamente, ya dijiste todo. Agradecer a todos los que nos acompañaron, agradecer a todos ustedes que están del otro lado, que siempre nos acompañan y hacen que esto sea un éxito, a Tecnoimagen, a los oradores, a Gabriel por todo el esfuerzo que tuvo, a las traductoras, que también sé que es un esfuerzo grande estar toda la mañana traduciendo y descifrando todos estos términos médicos y algunas clases complicadas. Así que mi agradecimiento para todos. Y bueno,
Yo también te quiero agradecer a vos, Darío, porque la verdad que sos el coequiper, nos llevamos bárbaro, y la verdad que coordinar todo, estar en toda esta organización, sería imposible si no tuviéramos esta dinámica. Agradecerles a todos ustedes, y aquí pueden escanear con el celular este código QR y en una palabra ¿qué significó este curso para ustedes? Que lo califiquen. Y después también contesten las preguntas de la encuesta online que nos sirven. Darío, ¿ya escaneaste? Yo
Gracias.
ya escaneé.
Yo ya escaneé, lo estoy contestando. Gracias, Cari. Para mí también es un placer poder trabajar en conjunto. Y bueno, vamos a ir viendo lo que nos van contestando y preparando. Ustedes ya a partir de mañana empezamos a preparar el próximo curso, ¿no? Que falta poquito. Uno cree que es dentro de casi 5 o 6 meses, pero es a la vuelta de la esquina.
Exactamente, y estamos trabajando en este próximo curso, el de abril, el de junio. Bueno, agradecerles a todos ustedes que un sábado estén compartiendo, bueno, viendo qué palabra se va reproduciendo más y se va poniendo más resaltado. Es excelente, excelencia, buenísimo, instructivo. La verdad que la generosidad de los disertantes, de los moderadores, fantástico
Sí,
todo.
dedicar
Muchísimas
todos
gracias.
un tiempo el sábado, el tiempo de familia por la mañana, para algunos, por la tarde para otros, realmente y todos ustedes, ¿no? Tuvimos más de 1000 asistentes que en casi toda la jornada. La verdad que para nosotros es un placer y nos ayuda, ¿no? Nos ayuda a seguir haciendo este tipo de eventos.
Exacto. Y no se olviden de contestar también la encuesta. Cuando cierren el Zoom les aparece una encuesta. Ahí también nos pueden poner sugerencias, qué temas les interesa para próximos invitados que también quieran que tengamos en cuenta. La educación es esto, es compartir.
Exactamente, Cari, ahí se va llenando. Todavía tenemos casi 800 personas en línea, así que la gente se queda, te quiere completar. Y bueno, les agradezco a todos los que mandan ahí, nos mandan saludos, bueno, etcétera, felicitaciones, etcétera, etcétera. Así que bueno, muchísimas gracias y creo, Cari, no sé si quieren poner el video o querés un poquito más.
Perfecto.
Seguir con las... Igual sigue, ¿no? ¿Sigue estando lo del Menti o se acaba en el momento? Eso es... ¿Lo pueden seguir completando?
Creo
Sí,
que una vez que... ¿Sí? Ok.
Así que bueno, después lo vamos a tener todo completo y el año que viene les vamos a mostrar. Así tenemos algo para que quede, ¿no?
Exacto.
Así que bueno, los que están, los saludamos a todos y hasta el año que viene.
Hasta el año que viene. Chao, gracias.